swelling that is characteristic for the disease with multi-organ involvement. Also, it's involving the serum IgG4 level and the pathological description of the specimen, which should include lymphocyte plasma cell infiltrate with IgG4 plasma cell with a ratio of IgG4 to IgG more than 40%. This criteria was evolved in 2011, and it was the most common criteria followed clinically to detect and diagnose the disease. In summary, if you have the three criterion, which is the clinical presentation or examination plus the serum level of IgG4 and pathology, this is the definitive diagnosis. While if you have the clinical examination of the disease with histopathology, this is probable diagnosis, and possible if you have the clinical presentation of IgG4 with high IgG4 serum level. Again, this criteria was used widely clinically till the new criteria released by the ACR and EULAR in 2019. It's more comprehensive, systematic criteria, and it helps to dissect the different presentation, different manifestation of the disease, and it helps to narrow the diagnosis and exclude other mimickers. It's contained of 4 steps, which is entry criteria, exclusion criteria, inclusion criteria, then the total inclusion scores. So the entry criteria is characteristic of clinical or radiological involvement of typical organ, or pathological evidence of inflammatory process that is contained lymphoplasmacytic infiltration of uncertain etiology. Step number 2, which is important, is the exclusion criteria, which is 5 domains. The clinical one, so if there is fever or no subjective response to steroid, this is one of the important exclusion criteria of the disease. Serology, if there is leukopenia, eosinophilia, or positive serology, ANCA or anti-DNA, SSA, RMB, or other specific antibody. Cryoglobulinemia also, if it's positive, this is one of the exclusion criteria. Although there are some case reports of overlap of IgG4 disease with lupus and ANCA vasculitis, but again, as a general rule, usually presence of positive serological marker is pointing away from this diagnosis. Presence of radiological finding that is suspicious for malignancy or rapid progression of the disease, also one of the exclusion criteria because it's pointed toward malignancy. The other 2 domains are the pathological or known to have an established diagnosis. If we see under the category of pathology, most of the changes are pointing toward either malignancy or invasive infection. So presence of malignant cells, presence of neutrophilic infiltration, extensive necrosis, and presence of granuloma, or are features against the diagnosis of IgG4 disease. Again, if the patient is known to have multicentric Castleman disease, Crohn's disease, or Hashimoto thyroiditis, this is features to exclude the diagnosis of IgG4 related disease. The third step is the inclusion criteria. Most importantly is the histopathological changes with the classical dense lymphoplasmacytic infiltration, also presence of obliterative phlebitis, and the classical sortiform fibrosis with different scoring for each changes will support the diagnosis. Also, the immune staining with respect to the IgG4 to IgG ratio and the number of IgG cells in the slide. Presence also of high IgG4 serum level with different scoring to the level, also respected in this criteria. The rest of the criteria is depend on the organ and symptoms. For example, presence of lacrimal, parotid, sublingual, and submandibular gland involvement will be scoring according to the number of organ involved. Uh, and so on in the rest of the organs, for example, chest or pancreas, kidney, or retroperitoneum involvement, with different scoring for different manifestation of these organs. So this criteria respected the number of organ and the manifestation in the organ itself as inclusion criteria. The step number 4, so the case or the diagnosis met the classification criteria for IgG4 disease if the entry criteria has been met and no exclusion criteria presence and the total score point in the inclusion criteria equal or more than 20. So it appears as a systematic, organized way to uh, reach the diagnosis of IgG4 related disease. As it's a new entity that has been described widely in the last 20 years, a lot of disease has been reclassified under the IgG4 disease. And in the coming few years, more diseases will be reclassified under this entity. For example, Meckel disease or Riddle disease of the thyroid, para-aortitis, and prostate infiltration. So we are still in the learning process of this disease. The uncertainty of this disease make it challenging to diagnosis. As we can see, any organ can be involved, and there is no specific symptoms, no specific or sensitive lab test to diagnose this disease. The most classical way and the gold standard way to diagnose this disease is by histopathological finding. As we can see in the previous diagnostic criteria, serum IgG4 has been incorporated in most of the criteria since 2001, but it's not specific or sensitive for diagnosis. 30% of patients with IgG4 related disease, they will have a normal serum IgG4. But from the experience and from the case series, the greater the number of organ involved, the more or the higher elevation in the serum IgG4 disease. As we mentioned that high level is not necessarily diagnostic for the disease, as it can be high in other types of malignancies. In a study about of autoimmune pancreatitis, the IgG4 level has been in the upper limit in almost 60% of the patients. And despite the elevated level, most of the patients remained in remission, and only 30% of them they developed a relapse with this high level. Again, 10% of patients with IgG4 related disease, they may develop relapse with normal level of serum IgG4. So the serum level per se is insufficient to make diagnosis of the disease. In real practice, most of the patients were detected by initial radiological investigation like CT scan, ultrasound, or MRI, but the best modality of imaging to diagnose and to guide the diagnosis in these patients is PET scan. Although the downside is of the PET scan is it's not available in all hospitals, and it's an expensive modalities. But usually it will guide us to know the burden of the disease, how many organs involved, and sometimes it can guide us for more accessible tissue for biopsy. So in a study, 9 out of 10 patients initially enrolled in this study with single organ disease were found to have multi-organ. The average of patients with IgG4 disease, they have 2 to 3 organ involved, and there are some case reports that patient had almost 9 or 10 organ involved. So again, doing PET scan can help us to guide for more accessible tissue for biopsy, and it helps us to compare the disease burden and activity in future after starting the treatment. The gold standard way for diagnosing IgG4 disease is by doing histopathological examination with the classical finding of lymphoplasmacytic infiltration, presence of fibrosis, and phlebitis. So the presence of at least 2 of these findings in combination of positive immune staining of the sample, making the diagnosis
and we'll move to the
high
next
probability
lecture.
with respect to the ratio
Excuse me?
IgG4 to IgG, although it's not a solid criteria.
So we apologize to stop this presentation at this time because Dr. Abdullah Al-Mutlaq, who will talk about ANCA-associated vasculitis treatment and therapeutic approach. So welcome, Dr. Abdullah.
Assalamu alaikum. Good morning, everyone. I would like to sincerely thank the organizing committee and the society for this humbling invitation. It's such a privilege to be here year after year, so thank you very much. Today, with addressing ANCA-associated vasculitis, we will try to answer. I cannot promise reaching any answers to these questions, but we'll try to answer 2 controversial questions, and hopefully you'll find interesting this capsule of information, interesting enough to keep you away from your phones, and helpful enough, hopefully, inshallah. A general overview, we're going to go over general principles and overview concepts. The 2 questions we're attempting to answer today is what is the role of rituximab in maintenance based on the most recent published data and the guidelines? And the second question, who is avacopan, or what is avacopan, and what is the role in inducing remission? And then we'll conclude with 1 slide of what does the landscape of treatment of ANCA-associated vasculitis, namely MPA and GPA, looks like. So we always stick to our vasculitis flag that was published in the Chapel Hill Consensus back in 2012, where we have large, medium, and small vessel vasculitis, either immune-mediated or non-immune mediated. So we will be focusing on the non-immune mediated, namely microscopic polyangiitis and granulomatosis with polyangiitis. General concepts in treating patients with ANCA-associated vasculitis. When we interpret any evidence that has been published, please be aware that these are quite heterogeneous cohorts, of course, due to the rarity of the disease and the difficulty of having a homogeneous group, either by clinical manifestations or even by the autoimmune profile. Second, it is still up to now known that PR3 ANCA-associated vasculitis have more relapses and more severe renal disease, but fortunately, they respond better to treatment. Another important general concept why addressing patients with ANCA-associated vasculitis is that when you see a patient, please be aware, is this a new active disease or just an irreversible injury? A very good example of that is the proteinuria. Is it a result of a scar that has been before, or this is a new proteinuria that needs a intervention at the time being? On the right-hand side, you will find what is classified as severe life-threatening disease, for example, CNS vasculitis or cardiac involvement. These are the key references. This is not only these are the references that we look at, but these are the key references with the guidelines. The EULAR guidelines, which has been updated in 2024, and then the ACR criteria in 2021, and also our fellow nephrologist colleagues in the KDIGO guidelines, which was published in 2024, and also there is a Japanese guideline that will give a different angle and a different perspective on how do you address these patients. Moving on to our first question. So rituximab has been receiving a lot of evidence in the past 2 years suggesting that is it the best treatment option for maintenance or not? And this, answering this question cannot start anywhere else than the MERITSON study, which was published in 2014, where 115 patients, mainly MPA and GPA, and mostly newly diagnosed, were induced with cyclophosphamide and then randomized either to receive rituximab or azathioprine. At 28 months, it was quite evident that patient on rituximab did much better in terms of relapses. And this was also sustained up to 60 months of follow-up. It sustained this difference between rituximab and azathioprine. It is also noticed that the frequencies of adverse event did not differ between the two groups. The MERITSON group conducted other two studies. MERITSON 2, simply they took patients and they randomized them in either receiving a tailored rituximab regimen based on CD20, CD19 titer and the ANCA titer, or just go with the standard of care rituximab every 6 months, and there is absolutely no difference. People who achieved remission in the MERITSON 2 were re-randomized again, either to receive placebo or received other further treatments with rituximab for further 4 doses, and there was no surprise to show that more rituximab achieved more remission, sustained the remission in these patients. And then they went another step, the MERITSON group, and they took these studies, the 3, and they pulled them into an analysis. So this is a summary of the 3 MERITSONs, and patient will fall into one of 5 treatment regimens, either azathioprine, or rituximab short-term, 18 months tailored and fixed, or 36 months of rituximab tailored and fixed. The results, after adjusting for prognostic factor, they followed these patients up to 84 months. And of course, most patients with, who sustained the remission were in the prolonged 36 months of rituximab, followed by the 18 months, and azathioprine had the most relapses and the less rate of maintaining remission. The second landmark study addressing rituximab in maintenance is the Ritazaram study. So here they included 170 patients. In contrast to the MERITSON, these were relapsing disease. The MERITSON included only mainly 80% of newly diagnosed patients. And then after rituximab induction, in contrast to the MERITSON where the induction was cyclophosphamide, they randomized patients either receiving rituximab, 1 gram for 5 doses every 4 months, or 2 milligram per kg per day of azathioprine. The relapse rate at the rituximab group was much lower at 24 months and 48 months as well. So another signal that rituximab maintained relapse for a prolonged period of time. And similar to the MERITSON, similar adverse events between the two groups has been noticed. Yes, rituximab is good. Yes, rituximab can maintain remission, but what is the price we pay? This is a study published in 2021 who followed 142 patients who received rituximab, and the main side effect that has been found is the hypogamma. Not only that, the hypogamma was sustained even up to years after discontinuation of the medication. In summary, overall, rituximab is good in maintaining remission and compared to other drugs, namely, as we've shown, azathioprine. Toxicity concerns like hypogamma and also vaccine response is also another drawback and downside. And the other question that needs still to be answered is how much do we keep these patients on rituximab and for how long? 2, 3, 4 years? Still, there are no consensus on this. Moving into our second question. Who is avacopan, or what is avacopan, and what is the role in inducing treatment, in inducing remission? So avacopan is an overall, is a oral selective C5a inhibitor, which drives neutrophil activation. In 2020, the classic trial, which is a phase 2 trial, showed that there is no safety signals. But 3 years to that, there was the CLEAR trial in 2017, which is a phase 2 trial with 60 plus patients who were induced with either cyclophosphamide or rituximab, and then added a randomized patient to 3 groups of treatment regimen, either receiving avacopan with no prednisone, or receiving high-dose prednisone of 60 milligram per day, or a third regimen which is hybrid between the two, which is avacopan, and the lesser prednisone, which is 20 milligram per day. And the result that avacopan was shown to replace prednisone without compromising the efficacy. This is a landmark study for avacopan, the famous Advocate trial, which was published also in the New England Journal of Medicine in 2021. Patients were induced with cyclophosphamide and rituximab, around 330 patients, and were randomized either to receive an additional avacopan of 30 milligram BID or a tapering dose of prednisone. What is very noticeable about the study that the cohort is quite heterogeneous. We can find renal manifestation up to 80% in patients. We can find ENT and lung manifestations. And also previous autoimmune or immune suppressive medication was quite heterogeneous between the groups, but mainly up to 60% received rituximab in the past. We can see that avacopan was non-inferior to steroids at 26 weeks in achieving remission, and also superior to that at 52 weeks. The signal that has been found, and we'll address this in the next question, the next slide, that it showed a beneficial effect on the renal function. Infections, of course, were more in the prednisone group, but also please note that the patients who received avacopan in the regimen also received steroid, yes, to a lesser extent, but they also received steroid to help them reach their remission. Subgroup analysis of 50 patients with severe renal disease. By definition, the patients with the GFR less than 20 were analyzed, and the signal was found that the response in GFR was much more in this group of patients with avacopan, with an increase in the GFR of up to 16 mil per minute compared to only 7 in the prednisone group. Other two post-hoc analyses, the first one addressing the ENT and lung manifestation, which was published just last month, showing similar response between the avacopan group and the prednisone group. Another post-hoc analysis published in August of 2023, addressing the effect of avacopan on patient-reported outcomes and quality of care measures. And avacopan group had a higher or better response in these two domains. The future necessitates that we need further data. So the AVACOSTAR group or AVACOSTAR trial started recruiting in September 2023. It is a non-interventional, multinational prospective study aiming to recruit up to 500 patients between patients who receive avacopan and patients who doesn't, and follow them up. As I've mentioned, the first patient was recruited in September 2023. And we are promised an interim report later this year. Hopefully, the final report will be in late 2030. In summary, avacopan in inducing remission is as good as prednisone and even superior as per the Advocate trial in 52 weeks. There are no new short-term safety signals, but look out for liver function tests while patients are on avacopan. Note that there is no high-quality data supporting the use of avacopan beyond 52 weeks up to date. Two questions that needs to be answered and yet to be answered. Is it worth from an economical point of view or not? Second, what is the role of avacopan in maintenance and refractory disease? We'll conclude with the last slide of the landmark of treatment in ANCA-associated vasculitis. For induction for severe disease, rituximab and prednisone are still Thank you. So rituximab and prednisone are still the mainstay of treatment, in addition to cyclophosphamide, and Plex and IVIG can be used in certain cases. As for maintenance, rituximab is taking the bigger share of treating patients and keeping them for maintenance. Prednisone tapering dose. Azathioprine, methotrexate can also be used. Leflunomide and mycophenolate, and also the new kid in the block, avacopan, in inducing remission. As for non-severe disease, methotrexate and prednisone, in addition to azathioprine, can be used. Leflunomide and mycophenolate. As for maintenance, as we use, nothing has changed. Methotrexate, azathioprine, prednisone, leflunomide, and mycophenolate can also be used. By that, thank you very much.
Thank you very much, Dr. Al-Mutlig. Actually, he spared us 7 minutes from his time. Thank you very much for that. Our next talk will be about demography and characteristics of giant cell arteritis in Saudi Arabia and some updates on treatment by Prof. Sultan Al-Migran. Prof. Sultan is a professor and a consultant of internal medicine and rheumatology at King Khalid University Hospital, King Saud University at Riyadh. Please, Prof.
السلام عليكم ورحمة الله وبركاته. صباح الخير جميعا. بسم الله والصلاة والسلام على نبينا محمد وآله وصحبه أجمعين. Thank you for your introduction, Dr. Suad and Dr. Abdulaziz. And thanks for the organizing committee for inviting me to deliver this lecture. As you can see, our lecture is about demographic and the clinical pattern of GCA in Saudi population. And then we will go to the update on the treatment. Before we proceed to our study, I want just to go briefly about the epidemiology of GCA globally. This is a meta-analysis of epidemiology of giant cell arteritis across the time and in different geographic locations. As you can see, the diamond down here in the graph, you can see that the pooled prevalence of the GCA globally is 51.74 cases per 100,000 population. And the pooled incidence of the GCA globally, again, is around 10 cases per 100,000 populations. And the highest incidence was in the Scandinavian group. It reached up to 21 cases per 100,000 population. The only studies from locally from Saudi Arabia is this two studies. Both of them came from King Khalid Eye Specialist Hospitals, and both of them retrospective. And the second study was done through the histology of the whole patient admitted throughout 22 years. They found that only 102 temporal artery biopsy was done, only 102. And they found that only confirmed diagnosis of GCA only in 7 cases. And they focus in the histopathological feature and on the visual complications. And this is why we decided to do a multi-center study from 5 tertiary centers in Riyadh. And this is a retrospective cohort comparative GCA study between Saudi and Swedish population. We identified from this around 63 cases of GCA. We excluded 2, and the final total number of our cases is 61 cases. And the Sweden-Lund GCA population registry is 1,320 cases. We are now in the process of matching one-to-one our cases with the cases of the Sweden-Lund GCA registry. And we are going now to disclose and present the demographic and clinical pattern of the GCA in the Saudi population. The author disclosed no conflict of interest in preparing this study. Our cases were identified based on GCA, ACR GCA, which is 1990 GCR classification criteria, or the ACR EULAR 2022 GCA criteria. If you can see here the clinical and demographic characteristic, the age at the diagnosis for both gender was, the mean was 67 years old. And the onset of symptom to the diagnosis is only 8 days. If you compare it with the European studies, the duration of the mean of the onset of symptoms to the diagnosis between 6 to 8 weeks. So the interpretation, even in UK study, they found that the mean duration and between the onset of the symptoms to the diagnosis, which is the delay in the diagnosis, is from 1 week to 32 weeks. So the interpretation of the short period of the delay of diagnosis in our GCA population, number one, that the frequency of visual complication in our study was very high. It was 59%. It was 59%. And the accessibility to the GCA, accessibility to the tertiary center, to the eye center and the eye hospital, this is the second interpretation. You can see also here the constitutional symptoms is only 38%. The constitutional symptoms is only 38% in our GCA population, while in the European population it reached up to 60%. And the PMR prevalence is only 13%. And you can see there is no discrepancy between both gender. There is no discrepancy except the PMR. The PMR is approaching statistical difference. It was 0.09. And the constitutional symptoms, the frequency is less in our population, while it is high frequency in the European population. And this is why most of the onset of the GCA is insidious. The onset, the constitutional symptoms, and the PMR and the non-specific headache will take weeks to months to manifest. You can see here the headache. The prevalence of the headache is 98%, which is high frequency, and the throbbing headache is 38%. And most of them, they have bilateral headache, and the temporal headache is only in 45%. The localized sign, temporal tenderness, and the temporal artery weakness is only between 16 and 48%. We come now to the visual complication. The visual loss, as we said, is 59% of cases that have visual loss. And the characteristic of the visual loss, which suggests the vasculitic rather than non-vasculitic, is the diplopia, which is around 8% only. And for the optic disc swelling, it is only 31%, and optic disc swelling can be in the arteritic or vasculitic, and can be in the non-arteritic arteritic optic neuritis. But you can see here the pillar, which is very characteristic for the GCA, is only 39%. Diabetes, prevalence of diabetes in the GCA was 64% in the GCA. When we found this one is very high, we reviewed the chart and we found that the diabetes prior to GCA was 61%. And we review even the GCA-approved biopsy, and we found that the prevalence of diabetes is 61%. The epidemiology, the prevalence of diabetes in the Saudi Arabia above the age of 45 years old is, it was done in Rabi'an study, it was 40%. And we found one study from Jeddah that the prevalence of the diabetes in the patient above the 60 years old, it was 60%. Regarding histopathological finding, the most important thing is the intramural infiltration of cells, and we can see that it is around 43%. It involves the intima and the media and the adventitia. And the granuloma is only rarely present. It is present in 7% of the patients. Most of the drug used was methotrexate and tocilizumab, and this is in the same line of the recommendation. I would like to acknowledge and thank the investigator and the collaborator from the 5 centers. Regarding the updates in the GCA, tocilizumab is the first-line therapy for the GCA. This is the ACTA study done in 2 parts. The first part is double-blinded, and the second part is open-label. And the analysis, this is the Kaplan-Meier, and this is the prevalence and the proportion of patients who achieved in the arm of tocilizumab was very high percent compared with placebo. You can see here that the sustained remission was 56% of the patients with tocilizumab and 53% in the alternate week of tocilizumab. The median dose of cumulative dose of steroid was much less in the tocilizumab group compared with the placebo group. Here, the second part, in the Kaplan-Meier, you can see the green line that the tocilizumab group, they sustained remission in the whole 2 years till the end of the study, and the percentage of those who sustained remission was around 42%. The cumulative dose of the steroid was almost 50% in the tocilizumab group compared with placebo. In the EULAR recommendation management, they recommend tocilizumab only for refractory and relapse, and not for the new unless the patient has high risk for the steroid. While in the ACR, which came after the completion of the GIACTA study, the recommendation is recommended tocilizumab even for the new cases. Regarding the abatacept trial, as you can see here in the Kaplan-Meier study, the sustained remission with frequency of the relapse-free remission was higher in the abatacept. And in the abatacetinib, the sustained remission in those who took abatacept 50 milligram was much higher than the control group. As you can see in the confidence interval, it is very significant, and the abatacetinib, it is reaching up to 48.4%. And the secukinumab, the same trial, the sustained remission in the secukinumab arm was much higher than the placebo, and the p-value is very significant. This is the summary for the previous drug and the other drug that the proved effective non-glucocorticoid drug was tocilizumab and the tocilizumab biosimilar Tyane. Both the tocilizumab is FDA approved, EULAR and ACR recommendation, and the Tyane, the tocilizumab biosimilar, also approved by the FDA as an interchangeable biosimilar. Methotrexate also one of the approved drug, and it is in the ACR recommendation. Abatacept also one of the recommendation of the ACR after the methotrexate and tocilizumab. This is a potential drug, which is the abatacept, secukinumab, mavrilimumab. And this is the low-quality drugs evidence, which is azathioprine, leflunomide, rituximab, and secukinumab. And the anakinra, it was terminated study, and the anti-TNF, 3 randomized clinical trial has been done, all of them ineffective. Thank you very much.
Thank you, Prof. Sultan Al-Mugarin, for the excellent work and the excellent presentation. So we'll open the floor for the question for the last 2 lectures only, because Dr. Abdurrahman Al-Rashid is unavailable for a certain reason. Any question? تفضل دكتور عبد الله.
Can we ask each other?
Yes.
Yeah.
تفضل.
MashaAllah, Prof. Mugarin, congratulations on the work that has been published. Just a question. What are the applications? What's the interpretation?
قرب من الصوت بس دكتور معلش. قرب من المايك.
واضح? Yeah. طيب. Congratulations, Prof. Mugarin, on the published data. My question is, what room for improvement can we do in addressing our patients, especially with the detection? You've mentioned that the detection can take up to 32 weeks. So what improvement you suggest in the clinical pathways, if we can have clinical pathways to implement in our practice?
Actually, the duration for the delay from the onset of symptoms to the diagnosis in our population was very short if you compare it with the European. And we said that the explanation, it could be from the high frequency of visual complication. This is why they present early to the hospital. And the second thing is the availability of the, and accessibility of the eye centers and eye hospitals. And the third thing, the constitutional symptoms is low frequency, while in the European it's high frequency. This is why those they present, insidiously, which will take months to present. As mentioned in the UK study, they said it might take 32 weeks, while in our studies only 10 days or 8 days. That's all.
تفضل دكتور.
Thanks so much. How can you explain the high incidence of visual loss? In your studies mentioned 59% in the setting of early diagnosis, about a week or 8 days.
The high frequency of visual loss, when we find it very high, this is for the whole GCA, whether it is biopsy proven or not. We identify the percentage of visual loss in the biopsy proven GCA. We found the same percentage. It was around 61. This is why we said that maybe this is a genetic or whatever, but it is very high frequency. We couldn't find any other explanation.
تفضل دكتور.
Thank you. Really nice presentations. One question for each of you. Firstly, Dr. Mutlaq, do we have access to Avacopan here in Saudi? What's the access of?
In general, yes. So we have access to Avacopan.
Great. Okay.
Yep.
2 years ago, I had an ankylosing and I couldn't find it anywhere, but perhaps
Still limited access,
right.
but there is access to Avacopan.
Perfect. Thank you. And Professor, regarding ultrasound, are you using ultrasound? I know in the UK we were using a lot more to diagnosis. It's more helpful, I find, compared with biopsy. And your thoughts? Ultrasound, vascular ultrasound.
Actually, the ultrasound, we have lack of experience with it in all centers. And actually, we are in the same line like SSRSA recommendation. The European recommendation, they consider the ultrasound as the diagnostic, even it is enough to diagnose the case without the histopathology. While the ACR, they mentioned in their recommendation, because of lack of experience, they said better to confirm it diagnosis by the biopsy rather than to rely in the ultrasound or MRI or MRA. Right. So we have a lack of experience with this ultrasound.
دكتور عبد اللطيف تفضل. You have a question? Yes. جاك المايك تفضل.
Thank you very much. For Dr. Abdullah, thank you for your excellent lecture. For how long you can use Avacopan, and is there any relapse or any recurrence of the disease, and can you use it again after the course of the Avacopan?
So as data suggested, there is no evidence to use it beyond 52 weeks. The new Avacostar will help hopefully address the long-term safety signals. On the short term, there are no safety signals, but you need to keep an eye on LFTs mainly as per the recommendations.
دكتورة هدى تفضلي. Yes.
يعطيك العافية دكتور عبد الله وبروف سلطان. Prof. Sultan, I'm very happy to see you again here. The first time we met in Lund University Hospital. And I'm happy to see the compared study between the Lund University Hospital and in Saudi. And I just want to add that maybe the comparison between the two centers, that in Lund that we have the fast track clinic, that each patient with high suspicion to have temporal arthritis or GCA, they have the very fast access to the ultrasound, as you mentioned. And I think that the comparison between the ultrasound and the biopsy is that which one is the cost effective for Europe compared to the ACR as well. Very good consultation, very good presentation. Thank you for to inform us about the results. Thank you.
Yes, I have a question for Prof. Thank you, Prof, for presentation. It's excellent. My question regarding with the high incidence of diabetes, Do you think that we will have the time that maybe a monotherapy of tocilizumab might, prevent the complication and the side effect of a steroid, for especially that we have high incidence of diabetes and the eye complication in those group as a monotherapy tocilizumab?
Yes, this is the recommendation for both the European and the ACR. They recommend if there is a high risk of a steroid complication, you have to start tocilizumab for the new cases. You have to start for the new cases. And the studies showed in GIACTA that it reduced the median cumulative dose of steroid up to 50%. It is recommended to use tocilizumab as early as possible.
Okay, can be used as a monotherapy?
There is one study done as a monotherapy, but it was the size of the studies was small, and they found it is effective. But in general, the recommendation, they prefer to use both tocilizumab with the steroid.
Okay, any further question? So before we conclude, I want just to thank Dr. Hanan and Dr. Fayed for excellent organization and for the invitation. And we will conclude here. Thank you, dear speakers, and thank you for the audience.
Okay, so thank you so much. I would like now to start giving the certificate, and thanks our speaker and our chairperson. So Dr. Sultan Mgheren. So Dr. Abdullah Al-Mutlaq. So Abdullah Al-Mutlaq is my roommate يعني دكتور سعاد حناوي. My friend دكتور محمد عطية. So now we'll move the satellite symposium.
Assalamu alaikum. Good morning, everybody. I'd like to thank Sanders for inviting me to talk about the Sanders etanercept biosimilar switch from randomized clinical trials to the real-world evidence. Okay, this is my disclosure. So the contents of my talk is going to look into the biosimilars background, and then we will talk about the phase 3 randomized trial, the Aquera study, and then we will talk about the real-world evidence coming from the COMBAT study, and eventually we will look into the insights into the patient and nurse perceptions about the auto-injector's sensor-ready device. So as you know, the biosimilars certainly makes an opportunity to improve the patient access to the biologics. And the introduction of the biosimilars had made a lot of competition in driving prices actually lower in the market. So you know that it gives us actually more treatment options and also increasing the access to the life-saving medications. At the same time, as we have already mentioned, that this competition is going to lower the healthcare cost through competition with reference biologics. So we end up having, cost savings relative to reference biologics may facilitate therapy of a broader spectrum of patients with rheumatoid arthritis. If you look into the evidence coming from the NHS regarding the cost, the NHS actually saved almost 324 million pounds in 2017 and 18 by switching from 10 actually reference medicines to biosimilars. Looking into the evidence coming from the clinical trials and real-world evidence, these kind of studies will help us actually know the efficacy, the safety of these actually molecules. And as you can see here from the studies done by Sandoz regarding their biosimilars, whether etanercept or adalimumab, we have these randomized control trials, the ADMIRA study of Sandoz for adalimumab, which included 353 patients. We have also the AQUIRA study for the Sandoz etanercept, which included about 376 patients, and also the SSRSA study, which is looking into a head-to-head trial between the Sandoz adalimumab and secukinumab. So we are also seeing head-to-head trials in the biosimilar market as well. So this is really great because it gives us actually more confidence in the data that are available for us to assess the biosimilar efficacy, safety over time. Now, looking into the AQUIRA study, which is a randomized, it's a phase 3 randomized double-blind parallel group study. This study actually, as you can see here, was done over almost 48 weeks. The primary endpoint was in 24 weeks. After basically the screening, which took about 4 weeks, they randomized the patient in one-to-one group between those patients who are using Sandoz etanercept, which included about 186 patients, versus the reference etanercept, which included about 190 patients. And you can see on the primary endpoint in week 24, those patients who were on the reference etanercept were shifted to the Sandoz etanercept to see if the switch would make any difference in terms of the sustainability and persistence of the drug efficacy, and also in the side effect profile safety. So we will look into these data shortly. You can see here the DAS20-CRP change from the baseline over 24 weeks was the primary endpoint in the treatment period number 1. And what you see here is that the Sandoz etanercept showed equivalent efficacy to the reference etanercept in terms of the DAS28-CRP. So there is significant reduction in both treatment of the DAS28-CRP over time, whether we're talking about starting from week 4, week 12, and then week 24. So you can see that there is the equivalent studies, and in fact, there is no difference between the Sandoz etanercept and the reference etanercept. The predefined range in the difference range is about 0.6, minus 0.6 to 0.6, which was not exceeded in this randomized control trial. So that indicates that the reference or the Sandoz etanercept is equivalent to the reference etanercept. Now, when you look into the DAS-CRP change from the baseline up to week 48, which is the treatment period number 2, when those patients who were on the reference etanercept was switched to the Sandoz etanercept, you can see this graph showing identical trajectory of the lines between those who were on the Sandoz etanercept or the reference etanercept, indicating similar improvement and equivalent reduction in the DAS28-CRPs, which indicates efficacy of this drug. When you look into the safety profile, it was actually comparable between the patient who continued Sandoz etanercept versus switched Sandoz etanercept with no new safety signals identified. And without going into these details of the numbers, you can see that they are more or less similar, and there is no signal indicating any change from what we have seen from the data about the reference etanercept. Again, if you look into the immunogenicity up to week 48, the incidence of anti-drug antibodies to the etanercept were small in general, and comparable between the patients who continued Sandoz etanercept treatment versus those who switched to the Sandoz etanercept. And in fact, although there was a small development of anti-drug antibodies, that did not impact actually the efficacy or increase the side effects of the drug. Now let's look into as we have already seen now, the randomized clinical trials, which is done in a controlled situations. The Sandoz etanercept real-world evidence helps us basically know about the efficacy of this drug and the safety in the real-world day-to-day practice. Because as you know, we have different patient ages and different comorbidities, which makes it more generalizable to our day-to-day practice. So this real-world effectiveness and safety of Sandoz etanercept, which is actually called COMPACT study, it's a multi-country study that was done on almost 98 countries across Europe and Canada, and included almost 1,400 plus patients. The patients were aged 18 years or above, and those who had rheumatoid arthritis, axial spondyloarthritis, or psoriatic arthritis, who initiated on Sandoz treatment. Treatment groups actually categorized by the prior therapy. So we have 4 groups here. Those patients in group A included those who had clinical remission with low disease activity with reference etanercept or other etanercept biosimilar, who were switched actually to the Sandoz etanercept. The group B included those patients who were on other targeted therapies, including other anti-TNF medications or targeted synthetic DMARDs, who were switched to that Sandoz etanercept. And the group C, actually, those who are biologic naive and they have inadequate response to the conventional synthetic DMARDs, who were switched to the Sandoz etanercept. The group D include the DMARD naive patients with recent diagnosis of RA considered suitable for biologic, and they were initiated on Sandoz etanercept as first-line treatment. So these groups categorizing prior therapies, actually. So if you look into the COMPACT study, which is the switching to the Sandoz etanercept was effective based on the high treatment persistence. So those patients, if you look in 12 months, they had persistence of the drug, indicating that the Sandoz etanercept was really effective and also safe, with no much of discontinuation of the drug. So as you can see here in this basically Kaplan-Meier analysis, the survival probability on the Sandoz etanercept treatment in the patient who had achieving low disease activity or remission on previous reference etanercept and switched to the Sandoz etanercept did the best in terms of the persistence. However, those patients who were on previous biologics and shifted to the Sandoz etanercept, they had lower responses, as you can see here, demonstrated by the green line at the bottom. So the overall Sandoz etanercept discontinuation rate were overall small. However, more than almost 80% of the patients were able to sustain the drug over time. And the Sandoz etanercept discontinuation rate was different among the different groups. In fact, if you look into the efficacy, there is actually improvement in those patients who were continued on the drug. The COMPACT study switching to the Sandoz etanercept was effective based on the maintenance of the disease activity scores at 12 months. And you can see this actually graphs indicating the disease activity scores over time with the Sandoz treatment. Overall populations were kind of consistent. And you can see that there is improvement in the proportion of the patient with RA in remission from 42% at the baseline to 51.7% at month 12. And the same thing for the patient with psoriatic arthritis. There is improvement from 53 to 62% almost. The COMPACT study, the patient reported outcomes with the Sandoz etanercept treatment. The patient reported outcomes remained stable over time with Sandoz etanercept treatment, and you can see it actually in this table, indicating that those patients who are on rheumatoid arthritis or psoriatic arthritis or axial spondyloarthritis, they had their patient-reported outcomes remained stable over time, as reported by the physical function, HAQ-DI, or fatigue, or the pain. Looking into the safety with Sandoz etanercept treatment, actually no new safety signals were observed after switching the Sandoz etanercept, and you can see it almost in here. Maybe slight, differences, which is not significant. So if you look into the conclusions from the COMBACT study, that result from the COMBACT study actually showed that switching from the reference etanercept or another etanercept biosimilar to Sandoz etanercept does not impact the effectiveness or safety of the treatment in patients with rheumatoid arthritis, axial spondyloarthritis, or psoriatic arthritis. And the disease activity scores actually were stable over 12 months of the Sandoz etanercept treatment, and treatment persistent rates were high, both in patients that were switched to the Sandoz etanercept and in biologic naive patients that initiated Sandoz etanercept. In fact, also, we have already showed you that there were no safety or new safety signals were perceived or observed with the Sandoz etanercept treatment compared with the previously published etanercept data. Now let's look into the patient and the nurse real-world perceptions about the auto-injectors used for the Sandoz etanercept, the auto-injectors sensory device in comparison to other devices with other biologics. And what you can see here, the first things, the patient and the nurse perception survey the rate attributes of the importance for the auto-injectors. The nurses and the patient, determine certain attributes that are important when you use an auto-injector device. One of them is the easy to perform self-injection, and you can see that both the patient and the nurses reported this as an important attribute. Easy to grab the pen is also an important attribute when you use an auto-injector device. And there are some other factors which differ from the patients and the nurses in terms of the scoring. Now, if you look into the comparison between the different auto-injectors, the SensoReady device that's used in the Sandoz etanercept, and comparing it actually, which is called here Erlezi SensoReady, versus other biosimilars like Benepali and Mali, the originator Enbrel, and the Humira Ben, you would notice that, for example, the overall satisfaction was really great for the SensoReady device, and also easy to perform for self-injection with the pen was also reported with the SensoReady device, indicating that it has basically good importance for using user-friendly devices for injections. So I will come here to the conclusions of my talk, and I will try to stress again the 48-week result from the Aquera study demonstrated that switching patients from the reference etanercept to the Sandoz etanercept did not impact the efficacy, the safety, or immunogenicity of the etanercept in patients with moderate to severe rheumatoid arthritis. So now we have the evidence from a randomized clinical trial showing that it is really effective and safe. The result from the COMBACT study showed that switching from the reference etanercept to the Sandoz etanercept does not impact the safety and effectiveness of etanercept, with high treatment persistent rates in patients with rheumatoid arthritis, axial spondyloarthritis, and PSA. So we have a wide range of diseases, and this drug is showing persistency over time. The other real-world data which presented actually showed no difference in the efficacy and safety after switching from the reference etanercept to the biosimilars with high retention rates. And the Sandoz etanercept SensoReady auto-injector was preferred by patients and nurses for its ease of use, and primarily due to its buttonless 360 injections, large dose window, and ergonomic shape. So with this, I end my talk, and thanks for listening. And if you have any questions, I'm ready to answer. Thanks a lot for you. Seems no questions, huh?
So now we'll move to the next session, which is about oral abstracts from rheumatoid arthritis, will be chaired by Dr. Mushabbab Al-Ghamdi. Is Dr. Mushabbab here? Yeah.
So Dr. Mshabab is an associate professor of rheumatology at the University of Bisha and a consultant of rheumatology at King Abdullah Hospital. So please, if you can come over here.
Bismillahirrahmanirrahim. Wassalamu ala Rasulillah. Good morning, everyone. It's my pleasure to be here today. So we'll have our session about oral abstracts, rheumatoid arthritis. We have 3 presentations. The first one, it will be by Prof. Alexander from Russia. Welcome, Prof. Go ahead.
Chairperson, distinguished colleagues, ladies and gentlemen, it is a privilege to be here today to present our findings on the impact of comorbidity burden on the efficacy of the interleukin-6 inhibitor olakizumab in real-world clinical practice. As we know, rheumatoid arthritis is a complex condition often accompanied by multiple comorbidities that can influence treatment response. Our study aimed to explore how these comorbid conditions affect the efficacy of olakizumab. A few words about olakizumab. Olakizumab is a humanized monoclonal antibody which provides a unique mode of action by direct inhibition of interleukin-6. Olakizumab selectively binds to human interleukin-6 and effectively neutralizes the effect of interleukin-6 in vivo and in vitro. Olakizumab is recommended for patients aged 18 years or older with moderate to severe rheumatoid arthritis in combination with methotrexate and who have inadequate response to methotrexate or tumor necrosis factor inhibitor therapy. Comorbidity is the norm rather than the exception in rheumatoid arthritis. Nearly a third of patients have at least one comorbidity at the onset of rheumatoid arthritis, with eventual involvement of nearly 80% patients during follow-up. A patient with established rheumatoid arthritis has an average 2 comorbidities. The study and awareness of comorbidities in rheumatoid arthritis is very important from both a research and clinical perspective. Post hoc analysis of the previous randomized controlled trial CREDA-2 data shows that the efficacy of the direct interleukin-6 inhibitor olakizumab is not significantly affected by comorbidity burden. Data presented on this slide, to be precise, on the left side of this slide. Our current research investigates whether a high comorbidity index affects the efficacy of olakizumab using real-world data to supplement controlled clinical trial findings. We included biologic DMARD naive rheumatoid arthritis patients with methotrexate corticosteroids inefficacy who received olakizumab for at least 24 weeks in our retrospective study in 63 sites across Russia. The Rheumatic Disease Comorbidity Index, RDCI, was used to assess the impact of comorbidities on efficacy. Currently, RDCI index offers the advantages of being simple to use and compatible with both questionnaires and databases. Efficacy was assessed at week 12 and week 24 using established disease activity measures, SDI, CDI, and DAS28 ESR. Propensity score matching was applied to adjust for confounding variables such as age, gender, disease duration, baseline CRP and ESR, joint counts, corticosteroid use, and physician and patient assessment. In real clinical practice, nearly 2,000 patients treated with alakizumab were analyzed. As expected, most of the patients, 72%, had comorbid pathology, 42% of them having more than 2 diseases. The main comorbid conditions were arterial hypertension, osteoarthritis, osteoporosis, gastrointestinal diseases. Diseases such as diabetes mellitus, ischemic heart disease, anemia, kidney and lung disease were present in less than 10% of our patients. Overall, 222 patients with rheumatoid arthritis were included in the analysis, all treated with olokizumab 64 milligram every 2 weeks or every 4 weeks. Patients were grouped based on their rheumatic disease comorbidity index score into 2 groups, RDCI low group and RDCI high group. Each group included 111 patients. The baseline characteristics of these groups were comparable as presented on this slide. The study yielded significant insights. No significant difference in efficacy was observed between high and low RDCI groups in alakizumab-treated patients. Patients in both groups achieved comparable rates of remission and low disease activity. This real-world study suggests that alakizumab remains an effective treatment option for rheumatoid arthritis patients, even in the presence of multiple comorbidities. In clinical practice, where comorbid conditions frequently complicate treatment decisions, this finding is especially relevant. Further research will help clarify the long-term impact of comorbidities on alakizumab outcomes and optimize treatment strategies for complex rheumatoid arthritis patients. Thank you for your attention. I welcome any questions and discussions on these findings.
Thank you, Prof. Have a seat. So the second abstract will be presented by Dr. Mufaddal Al-Aithan. موجودة. لا بس في الدكتور مفضل موجود لا موجود. Welcome, Dr. Mufaddal, and the stage is yours.
Assalamu alaikum wa rahmatullah. Bismillah ar-Rahman ar-Rahim. Before I start, I would like to thank the organizing committee and the president of the SSR, Dr. Hanan Al-Rayis, for this wonderful and scientific event. And I would like to show my appreciation for this generous invitation for me to present this abstract. So before I start, I would like to disclose to you, as many of you know, I am a full-time employee and a shareholder for Eli Lilly. So I will be talking about the effectiveness of baricitinib versus all other biologics and targeted synthetic DMARDs from the RAB real study, and this is the 2 years data. So a little bit of background here is, as we all know, in the practice, treat to target is what we aim to get in rheumatoid arthritis. And baricitinib, as we know, it is an oral selective JAK1/2 inhibitor that is approved for the treatment of rheumatoid arthritis as well as many other indications, including alopecia, atopic dermatitis, and even COVID in some countries. So the RAB real study is an ongoing study that is a real-world prospective multinational observational study that looks into the real-world effectiveness and the time to discontinuation for medications in treatment of rheumatoid arthritis. So the objective of this abstract is to report on the early achievement of remission, low disease activity at 3 months in the real world, and to explore the long-term consequences of achieving such. So this is the overall design of the study. There's an early period of retrospective data collections and assessing the medications. And then starting from day one of enrollment, patients would be followed typically for up to 3 years and with a window of follow-up. And then patients are generally grouped into 2 cohorts, a baricitinib cohort and a cohort B that is lumped into all other biologics and targeted synthetic DMARDs. Okay, so the study basically started in October 2018 and is continuous till now, but this report is up to March 2020, and this report includes patients from the European cohort in the study. So the cohort A includes patients who were on 2 doses of baricitinib, and cohort B is for patients on all other biologics and targeted synthetic DMARDs. So it included adult patients with rheumatoid arthritis who were diagnosed by the physician in the clinic, as well as with any real-world evidence study. And baricitinib prescription was basically on label, and it excluded any simultaneous participation in any other trials or other investigational medicines. So the baseline data effectiveness are presented and then at 3 months and as 2 years as well, and we look into remission and low disease activity by CDAI at 3 months and comparing those who achieved it to those who did not achieve it. We also looked into the treatment discontinuation between 3 and 24 months, and the data are presented in a descriptive analysis as in percentages. So what we see here is that the red chart is for baricitinib, the blue is for other medications or biologics or TSDMARDs, and the dark portion is those who achieved low disease activity or remission. The pale portion or the faint one is for those who did not. We can see that baricitinib achieved it in almost 60% compared to almost 50% in the other group. So when we look at the demographics for patients at baseline, we see that patients who were on baricitinib were generally slightly older, but those who did not receive or did not achieve remission or LDA at 3 months were generally also just a tad older than the other cohort that achieved early remission or LDA. Other than that, we can see the duration of the disease were generally slightly longer for patients who did not achieve early remission or LDA, and they tend to be also more bio-experienced patients. When we look at remission or LDA at 3 months, we can see that it was achieved by, this is a change from baseline. We can see there was a change from baseline for baricitinib up to 15 points reduction and up to 14 points reduction at 3 months for all other medications. And by 2 years, it was maintained by baricitinib, whereas it went slightly down at 2 years for the other medications. We can see the change from baseline early in those that did not achieve early remission. LDA was much smaller, and yet at 2 years, some of them grow on to achieve remission or LDA. Now we can see the quality of life for early achievers of remission or LDA were significantly improved, and it was much better than those who did not achieve early remission or low disease activity, and this is true for all measures of quality of life and physical activity. Now, when we look at treatment discontinuation, we can see that very fewer patients discontinued the treatment if they achieve remission or LDA early compared to those who did not. And we can see baricitinib, interestingly, had the lowest rate of discontinuation if you achieve early remissions. So in conclusion, this is a real-life setting study that showed up to 60% of patients treated with baricitinib and up to almost 50% of patients treated with other medications achieving remission or low disease activity by 3 months. And this achievement was associated with better outcome at 2 years, and improvements in major outcomes were greater in 2 years in those who achieved it early compared to those who achieved it late. So this highlights the speed of efficacy is not only for a faster onset, but also this translates into a long-term gain. The study is not without limitations. This was a non-randomized observational study, so bias could not be totally excluded, and this is not a comparative analysis that is conducted here, but only a descriptive analysis, yet comparative analysis was published in another abstract or manuscript. So to summarize the key findings, that we have near 60 and near 50% of patients achieving remission or LDA at early point in 3 months. That is for baricitinib and other mechanism of action respectively, and improvements at 2 years were greatest for those who achieved it early at 3 months. That was my talk. These are the references and these are the disclosures, and thank you very much.
Thank you so much, Dr. Mufaddal, and welcome to the stage. So the next abstract will be presented by Dr. Sumaya Khawaji. She's not here. Huh? So we'll move to the last abstract presentation, which will be by Dr. Ghaida Addabi from Kuwait. Senior specialist in rheumatology. So she will present insights into rheumatoid arthritis in Kuwait and the prevalence of comorbidities. Dr. Sumaya, أهلا. So طيب تفضلي دكتورة غيداء. Go ahead.
So good morning, everyone, and thank you very much for accepting our abstract to be presented today in the conference. So I will be presenting on the behalf of my colleague, Dr. Mohammed Khadada, who could not be with us today. And our abstract is titled as Insights into Rheumatoid Arthritis in Kuwait, the Prevalence of Comorbidities. So rheumatoid arthritis is a chronic inflammatory disease and is a risk factor for cardiovascular disease. Cardiovascular disease mortality is 50% higher in rheumatoid arthritis, and this percentage is comparable to what has been reported with diabetes. The relation between comorbidities and rheumatoid arthritis is well known and is associated with poor outcomes. So our study investigates the epidemiology of rheumatoid arthritis in Kuwait and also assesses the prevalence of comorbidities, including modifiable cardiovascular risk factors, such as hypertension, diabetes, hyperlipidemia, and obesity, using the Kuwait Rheumatoid Arthritis Registry. So this is a retrospective analysis of a prospective collected data of 2,239 patients enrolled in the Kuwait Rheumatoid Arthritis Registry from February 2012 to May 2024. Baseline characteristics and reported associated comorbidities were analyzed. So what did we find in our cohort? So 2/3 of the patients in our cohort, actually they are females, and this is consistent with what we know about rheumatoid arthritis. So this disease, as we know, affects females more than males. The mean age of the patients is 55, and the mean disease duration is 11 years. What about BMI in our cohort? So the mean BMI is 29, but as you can see, 39% in our cohort was labeled as obese because their BMI is more than 30. 11% of our cohort they are smokers, and as you can see, ACPA or rheumatoid factor positivity is reported in 58% in our cohort. So what about the prevalence of comorbidities? We have different comorbidities detected in our cohort, as you can see, but if we will focus on the modifiable cardiovascular risk factors, we will talk about BMI. Again, it was reported to be more than 30 in 39% in our cohort. If you are interested to know how many in our cohort have healthy weight category, they were only 24%, unfortunately. Other modifiable cardiovascular risk factors reported in our cohort were hypertension, reported in 23%, followed by diabetes, hyperlipidemia, and as you can see, coronary artery disease was reported in 3% in our cohort. So what did we do when we found these findings in our cohort? We tried to compare our findings with what we published already in 2016. So in 2016, our sample size, if you are interested, was 1,500 patients. And a gentle reminder to what we have now in our cohort, or what we analyzed in our cohort now, the sample size is 2,239 patients. So again, we tried to compare what we found currently in our cohort with whatever published in 2016 in our cohort. And also we tried to compare it with our rheumatoid arthritis cohorts in the Gulf region, including what has been reported in Saudi Arabia, Qatar, and United Arab Emirates. And what has been reported in different countries in the Middle East, we found publication from Lebanon. And also we compared it with what we found from worldwide publications, so 3 publications from different other countries. So what did we find? If we focus on obesity, diabetes, hypertension, dyslipidemia, and smoking, the prevalence of these comorbidities is kind of comparable to what we found in the cohorts from Saudi Arabia, Qatar, and United Arab Emirates. But it's slightly different than what has been reported in Lebanon and worldwide. So what did we learn from this study? This study reveals a high prevalence of hypertension, diabetes, dyslipidemia, and obesity, and as we know, all of which are modifiable risks for cardiovascular disease. The prevalence of cardiovascular modifiable risk factors is somewhat similar in different cohorts in the Gulf region. What did we learn again from this study? This study emphasizes the importance of incorporating screening for such comorbid conditions in the care plan for rheumatoid arthritis patients, and optimizing management protocols to reduce morbidity and mortality and improve overall patient outcome. So besides just treating joint pain, joint swelling, and focusing on disease activity, we have also to make sure that we are assessing for other comorbid conditions, as I highlighted earlier, to improve more and more the quality of the provided care to our RA patients. And by this, I will conclude my abstract presentation, and thank you very much.
Thank you so much, Dr. Aida, and welcome to the stage. So again, welcome Dr. Sumaya Khawaji. She's a consultant in internal medicine, clinical pharmacist at National Guard. She will talk about evaluation and safety of JAK inhibitors in rheumatological versus other inflammatory diseases. Mic is yours.
Assalamu alaikum. Good morning, everyone. It is my pleasure to present our research result in this great conference. So as introduction, the JANS kinase inhibitor, it is represent the significant advancement in the treatment of the rheumatoid arthritis, offering treated these therapies for patients not respond adequately to the DMARD. This oral agent working by interfere with the state signaling pathway, which play important role in the inflammatory response. Among the patients with rheumatological disease, such as rheumatoid arthritis and psoriatic arthritis, the JAK inhibitor demonstrate efficacy in reducing disease activity and improving the patient quality of the life also. However, their safety profile has highlighted concern regarding the serious infection and thromboembolic event and cardiovascular event. A higher rate of malignancy and cardiovascular complication was reported in oral strategy study conducted among the patients with high-risk rheumatoid arthritis. As a consequence of this finding, the FDA labeled all JAK medication as the black box warning. Therefore, our study aimed to evaluate the safety of JAK medication in patients with rheumatological disease versus other inflammatory disease without restricting the JAK and the risk factor for the type of JAK used. So the study was a retrospective study, was conducted among the patients with rheumatological disease using either tofacitinib or obadacitinib or baricitinib for all use indication from January 2017 until February 2024. And the data was collected by using data collection sheet, including the patient demographic data, lab result, treatment, concurrent medication, adverse event, hospitalization, and the treatment discontinuation also. For the inclusion criteria for this study, we include the patient age 14 years and older, and the patient being treated with either tofa or baricitinib or obadacitinib. For the exclusion criteria, we exclude the patient either start on tofa or obada or bari for less than 3 months and lost follow-up. For the primary outcome of the study, we assessing the incidence of serious side effect, either cardiovascular complication or thrombosis or malignancy. For secondary outcome, the need for hospitalization due to the infection and other cause. And the secondary outcome, the rate of discontinuation of the JAK due to the side effect or the treatment failure. So our result of this study, this is the baseline characteristic. We include 298 patients, 228 patients in rheumatological disease and 70 patients in other inflammatory disease. The major of patients in rheumatological disease were female and older. And here is the comorbidities included in our study. The common comorbidities patient in rheumatoid arthritis. And here showing the indication of JAK used in study. The common indication in rheumatological disease was rheumatoid arthritis by 90% versus other inflammatory disease, the most common indication, psoriatic alopecia areata. And here is the duration. The duration was similar between rheumatoid arthritis and other inflammatory disease, 17 versus 16 months. And the common medication used in rheumatological disease was obadacitinib, followed by tofacitinib, and the common medication used in other inflammatory disease, obadacitinib versus tofa versus obadacitinib. And the primary outcome, the incidence of serious adverse effect, we report that it is the patient in rheumatological disease develop cardiovascular complication by 0.9%, and the malignancy by 1.3%, and thrombosis by 0.9%. Versus other inflammatory disease, no patient develop cardiovascular complication, and 1.4% develop malignancy, and 1.4% patient develop thrombosis. For the need for hospitalization due to the infection and other cause, 5.3% admission due to the infection in the rheumatological disease versus 5.7% in other inflammatory disease. The admission due to an infectious cause for patient in rheumatological disease versus 7.8 patient in other inflammatory disease. Actually, we report that the anemia developed in rheumatological disease by 1.3% versus 7.1 in other inflammatory disease. For the discontinuation rate due to the side effect, 3.5% rheumatoid arthritis patient discontinued due to side effect versus 5.7 patient in other inflammatory disease. The discontinuation due to the failure, 8.8% in rheumatological disease versus 14.3% in other inflammatory disease. As conclusion, we conclude that in this study, the patient with rheumatological disease had higher rate of comorbidities and were older, and the rate of side effect was numerically higher, which required long and more extensive study to evaluate the difference. And however, that was also suggested that the rheumatological patient carry higher risk of side effect, and probably due to the higher presence of comorbidity. And thank you for your attendance.
Thank you, Dr. Sumaya, and welcome to the stage. So we'll have some. So the floor is open for questions. If you have any questions to our colleagues. So I have a question to Prof. Alexander. So the beauty of your paper that they did the logistic regression. So they adjust all the cofactors. So even though they adjust all the cofactors, it does not affect it by the IL-6 treatment. Any explanation for that? And is there any difference between the IL-6 in terms of presence of comorbidities? So if we have a comorbidity, isn't it? So in your paper, they adjust the cofactor with logistic regression. They did it very well. So it does not affect it by the IL-6 treatment, isn't it? Is there any difference between your IL-6 and the other types of IL-6 from your literature review? You can, with the mic, you can answer. What is the difference between the IL-6? So you talk about which one of them? Another one.
Yeah,
others.
I see. Thank you very much for interesting question, because this is very specific question concerning the alakizumab. Because, yeah, you are right. We have a group of inhibitor of interleukin 6. And the logic question is, what differ alakizumab from other inhibitor for interleukin 6? And here I should stress very important fact that the structure of the molecule of alakizumab differs absolutely from other inhibitor of interleukin 6. And the main idea is that the molecule of alakizumab consists of immunoglobulin G4. If we compare with the other inhibitor of interleukin 6, they consist of immunoglobulin G1. And you can ask, what does it mean? It means that immunoglobulin G4 absolutely neutralizes so-called cytotoxicity. Cytotoxicity influences the side effects during the treatment program and the immunogenicity. This is very important point to us.
Thank you so much. Thank you, Prof. So just a question to Dr. Mufaddal. Regarding the main concern of your paper, you mentioned it in the limitation. So they didn't adjust the cofactors, so independent variable not adjusted, and they didn't do the comparative analysis. Any explanation for that?
So the abstract I presented is, the main objective is to compare early achievers of remission, LDA, to those who did not, and understand how early achievement of remission, LDA, makes a difference for patients in other things like pain, quality of life, and would that lead to a long-term gain at 2 years. So comparative analysis was published in a separate paper that looked into the response rates for baricitinib cohort and a cohort of other medications, as well as, the regression analysis for other possible risk factors was also addressed in a separate paper, looking into the effect of the duration of the disease, smoking status, etc., etc. So the main aim of this abstract is to understand the gains of early remission LDA and how does it reflect on the patients for up to 2 years, so on the long run. So that was what I presented. Thank you.
Fair enough. Thank you, Dr. Mufaddal. Any further questions from the audience? So thank you all. We conclude our session.
So we'd like to thank the chairperson, Dr. Mushabbab Al-Ghamdi, for his contribution in this session.
Ultra beats on the track.
Prof. Alexander. دكتور مفضل. دكتور غيدة. دكتور سمية. Chair for all of us together. Thank you so much. So now we'll move to the session of rheumatoid arthritis. Will be chaired by Dr. Ahmed Al-Hazmi, the Senior Consultant of Rheumatology, Lupus and Vasculitis at King Fahd Armed Force Hospital in Jeddah. Also, I would like to invite Dr. Ma'touqa Ba'amir, as a Consultant Rheumatology at the First Clinic International Medical Center Hospital in Jeddah. Ahmed. Ahmed.
Assalamu alaikum wa rahmatullahi wa barakatuh. First, I would like to congratulate Dr. Hanan, Dr. Fahid, and Dr. Maysoon for this great conference and for the excellent scientific content, for the excellent organizations, and the great speaker. Our sessions consist of, it will be about rheumatoid arthritis. We have 2 speakers and 2 lecturers. The first speaker is Dr. Manal Hassan. Where is Dr. Manal? Yeah, Dr. Manal is an assistant professor of internal medicine at Imam Abdurrahman bin Faisal University in Dammam, and she is a consultant rheumatologist and head of rheumatologist division at King Fahd University Hospital Al Khubar. Her topic will be an overview of late onset rheumatoid arthritis. Please, Dr. Manal. Thank you.
morning, everyone. So thank you to the SSR for asking me to present this talk. And I have to apologize that most of the slides is going to be an overview rather than an update. So looking at insights and the differences between late onset and young onset rheumatoid arthritis. So as this name implies, I'm going to talk about the differences between young and elderly onset rheumatoid arthritis, the differential diagnosis and clinical presentation of the disease, the comorbidities, and the challenges in managing the disease. So why is it important to talk about EORA? The fact is, 1/3 of our patients actually present with a new onset rheumatoid arthritis after the age of 60. And in some literature, it's actually defined as a late onset that is after the age of 65. In fact, this was realized because in the Finnish population, since the 1990s, we have noticed that the age of onset of rheumatoid arthritis has increased from 50 to 57.8. And in the Japanese population, where most of the data about the elderly onset rheumatoid arthritis comes from, the age of peak of rheumatoid arthritis is no longer between 50 and 59, but rather 60 to 69. And it's not rare to find a patient in Japan who is presenting for the first time as rheumatoid arthritis at the age of 70 or even 80. It's important to realize that the aging population is actually increasing. And we know that by 2020, people above 65 outnumber children. Is it because there is an improvement in the quality of life or that there are less children? The fact is that number will keep increasing, and most of them will be living in low or middle income countries. And in fact, the number is doubling from 12% to 22% by the year 2050. So that's an important population to look at. And as rheumatologists, that adds to the burden of disease activity control and preventions of joint damage that you have to keep looking into the physical disability due to aging in addition to all the comorbidities. So what are the differences between late onset and young onset rheumatoid arthritis? The first difference is in the gender. You will notice that as the age increases, you have an equal proportion of male to female. And that's understandable because as we age, the drop in estrogen and the drop in androgen has its impact. Less estrogen means increasing incidence of rheumatoid arthritis, and lower androgen means less estrogen means reduced incidence in females, and lower androgen means an increased incidence in rheumatoid arthritis in males. When it comes to the clinical presentation, you will see that both of them commonly affects the hands. However, you will find that there are more young patients with metatarsophalangeal joint involvement, and that the late onset is more characterized by shoulder involvement, i.e. proximal joint involvement, more than the young population. In the synovial level, a comparison between the two was made, and it seems like at baseline, the elderly onset has more common synovitis, increased Doppler activity, and even with treatment, if you reach your target treatment of DAS28, you will find that the synovitis indices still persist in the elderly onset rheumatoid arthritis. So is it or is it not the same disease? That's still a question. The systemic manifestations are more common in late onset rheumatoid arthritis. These patients generally present with more fatigue, more weight loss, more anemia, higher ESR, and higher CRP values. And in fact, we have evidence that with increasing age in the late onset, you have increasing interleukin-6 level, but less so with the TNF. And that can have an implication on choosing which medication to choose. Other inflammatory markers, such as the platelet to lymphocyte ratio and the neutrophil to lymphocyte ratio, are used generally to impact the prognosis of the disease. And you will notice that with the late onset rheumatoid arthritis, you have a lower platelet to lymphocyte ratio, but a comparable neutrophil to lymphocyte ratio. And that is understandable because as we age, the platelet counts actually decline. However, the platelet reactivity increases. We know that in the late onset rheumatoid arthritis, you have a higher WBC count, a higher absolute neutrophil count, but there is absent lymphopenia and absent thrombocytosis. The jury at seropositivity is still out there because you will have conflicting results. We know when we teach our students that as we age, there are more chances of you having falsely positive antibodies. But when they looked at the late onset rheumatoid arthritis, it was actually not like that. These patients tend to have less seropositivity to rheumatoid factor as compared to the young. And when looking at the ACPA levels, you will have cohorts where it's actually either more or less than the younger population. You will also find cohorts that tell you that they're exactly the same. whether you're talking about a late onset or a young onset rheumatoid arthritis. But it still has its impact on prognosis. It's still the predictor of the presence of erosions or the development of erosions. And there was actually one study looking at those seropositive patients. And it seems that in the young onset rheumatoid arthritis, you have a 10% chance of developing erosions, even if you control the disease. But if you look at the late onset rheumatoid arthritis, that number goes up to more than 25%. Now, there are still talks about the genetic predisposition and what genetics are associated with each disease, and you will find conflicting results, so I'm not going to focus on that. And this is just a summary of what I said, if you like taking pictures, the clinical presentation difference, and the serological difference between the two. Now, when you diagnose a patient with late onset rheumatoid arthritis, he either fits into one of three categories. They're either rheumatoid arthritis-like, they're either PMR-like at presentation, or the disease that we heard about at fellowship, recurrent, symmetric, seronegative synovitis with peripheral edema. As the name implies, when they present with a rheumatoid-like disease, they have positive seropositivity for ACPA and rheumatoid factor. They're more likely to develop joint erosions, and that generally has a worse prognosis than the young onset rheumatoid arthritis. 25% of those patients actually present as polymyalgia rheumatica, i.e. they're seronegative, and they present with shoulder involvement. And in fact, if you diagnose a patient with polymyalgia rheumatica, 25% of those can have an asymmetric non-erosive polyarthritis. So how can you really tell the difference? The predictors of actually having a patient move into the diagnosis of elderly onset rheumatoid arthritis from PMR are simply rheumatoid factor positivity and then the Doppler ultrasound findings on the ultrasound of the hand. And there is interchanging pathogenesis theories that say the interleukin-6 and interleukin-1 beta is increased in both diseases, but it's still not well understood. And the least common presentation, which is the recurrent seronegative symmetric synovitis with peripheral edema, is actually the best prognosis. These patients tend to respond to a lot of steroids, maximum by 18 months. Remember, when you're diagnosing a patient with elderly onset rheumatoid arthritis, not to miss a paraneoplastic syndrome, which is a very important differential diagnosis in this entity. And just like any rheumatoid arthritis, we heard several talks about the comorbidities that commonly exist, except now with the elderly population, they're more common. And let me introduce you to the new concept of multimorbidity rather than using the term comorbidity, because when you use a term like comorbidity, you're acting like your disease is the center of attention, and then everything else happened with it. Whereas the term multimorbidity implies a patient that is the target of focus, and then everything else should be managed in order to address the concerns of that patient. Multimorbidity is important because every single disease has a disability, including aging itself. And in fact, it's expected that as the population ages, we're going to see less patients with 0 or 1 disease, and more patients with 2, 3, or even 4 diseases. So you have to take that into consideration. And each one of those diseases, in addition to rheumatoid arthritis, adds not only to the disability as we are aware of it, but to the actual HAQ score and the outcome of the disease. 4 comorbidities that are of specific importance in the elderly population and shown in the slide. And of course, we know that in addition to the traditional risk factors, these populations tend to have a high serum creatinine, a high serum uric acid, both of which also contribute to their cardiovascular risk. The risk of infection in all literature is also increased by increasing age. But in addition to that, remember that you have to control the higher disease activity. They have an additional factor of disability and immobility, and you add to that immunomodulatory drugs. The most common infections of all are respiratory and urogenital infections. When it comes to increasing malignancy, we all know that there is an increased risk of lymphoma. However, the solid malignancies have been looked at in different cohorts. And I'm just going to point out this cohort from California that was recently published, where it was found that there is an elevated risk of lung, liver, and esophageal cancer in males, whereas there was a lower risk of prostate, breast, ovary, and uterine cancer, which was kind of weird because we were taught that you have to look for malignancy when you have rheumatoid arthritis. So when you look at those cohorts, remember the facts. And the fact is, if you look at breast CA, it's more common in women under the age of 40 and in non-Caucasian. So the population studied is important. And regardless of the age of the patient, the prognosis of breast cancer is worse in women with rheumatoid arthritis. And in fact, the mortality is increased by 40% as compared to those who don't have rheumatoid arthritis. So regardless of your age, you have to do screening that is age and risk factor appropriate for all your patients with rheumatoid arthritis. We do not have yet cancer risk stratification for elderly onset rheumatoid arthritis, but these are general guidelines. Lung disease, again, attributed by disease itself, comorbidities, medication, infection, increases with increasing age. And in fact, the most important risk factor for the development of ILD and rheumatoid is an older age at the onset of the disease. Why this matters is because the presence of ILD with rheumatoid arthritis adds a threefold higher risk of mortality as those without interstitial lung disease. In fact, there is 13% excess mortality of ILD and rheumatoid arthritis as compared to ILD without rheumatoid arthritis, and it tends to worsen the prognosis and the survival. So having all these concerns kept in mind, how are we doing about in managing elderly onset rheumatoid arthritis? We still have the same goal set in EORA as the young population, but it's not that easy to accomplish. For example, let's look at steroids and how we are using them. Now, most of the studies are retrospective observational cohorts, and mostly from Japan, because that's where the data come from. And you will find that most of them were actually using steroid more in that population, and in a higher dose or a longer duration than the others. There was one interesting study that was published around 2 years ago. The GLORIA study looked at the effect of steroids given at 5 milligrams for people 65 years of age or older. And what's interesting is they reported that if you look at the graphs, those people on steroids actually did better. But there was lots of co-founders because of co-intervention in that population. What was interesting as a rheumatologist looking at this paper is there was 1/3 of that population already having osteoporosis at baseline, and only 13% of them received management for that. And although they reported a slower or a lower rate of infection, we noticed that there are some patients who actually had little number of infections, but the majority of infections happened in those. And so their bottom line was that steroids are good with a trend of 11% increase in side effects. But what we would take of that is that the use of biologics was actually very rare in that study. People are still scared of using biologics in the elderly group, and that perception of risk factors, we know that steroids are harmful, is not actually translated into action. You will find that steroid use is not only increased in percentage, but in doses among rheumatoid arthritis patients that are diagnosed at an older age. And when you look at the trend of steroid use in rheumatoid arthritis in general, you will find that despite that surge in the biologic use, the steroid use hasn't changed much. And although we would like to think that it is non-rheumatologists that use it more, you will find that our trend as rheumatologists hasn't changed as much. And in fact, most of that use is actually chronic. That is more than 9 months of steroid use. And this is rheumatoid arthritis we're talking about, not lupus. What about the other DMARDs? So when you look at hydroxychloroquine, there is no question that we know about the side effects. But imagine looking at a 70-year-old, telling him that you will use hydroxychloroquine and sending them to the ophthalmologist for screening. And you will find more than half of them either already having retinal thinning, diabetic retinopathy, or just not willing to follow up with the ophthalmologist in addition to whatever he has to follow up. But when we do use hydroxychloroquine, it has its protective effects on the cardiovascular risk, the development of diabetes, non-alcoholic fatty liver disease, and in LAURA per se, it has been proven to improve survival. Not only in the general population with rheumatoid arthritis, but in fact, even if you have malignancy, hydroxychloroquine is said to be much better. People on hydroxychloroquine who actually have malignancy had a much better survival than those not on hydroxychloroquine. Methotrexate is still a preferred use in elderly onset rheumatoid arthritis, but it has its problems as well. You will notice that although the use of methotrexate is still there, when you go to doses about 15, the dose tends to be lower. We do not go to higher doses with the elderly population. Add to that the fact that most of them will have side effects, and in some terms, it's the renal dysfunction that limits your increase in the dose. And so you can totally understand why a rheumatologist might not like to increase methotrexate, either because of a decreased renal function, a low albumin, or just a tolerance issue of methotrexate in that population. And that's why we have a higher rate of discontinuation. In fact, in the NINJA study, they looked at people above 75, and the discontinuation rate was so high that most of the people actually just stopped the drug and started using steroids. This is a paper from Korea showing at the trend of the use of other DMARDs, and that's why you will find butylamine and cyclosporine among the medications. But you can see that most of the elderly population with new onset rheumatoid arthritis tend to use a single rather than a combination DMARD, and that most of them actually use methotrexate and to a lower extent sulfasalazine. Leflunomide use has been increasing gradually. What about the biologic therapy? We've been warned about infection with biologics, but it's not only because of the age. Remember that with age comes comorbidities, and additional comorbidities simply mean increased risk of infections. So what about the effect of specific comorbidities in the elderly? Specific drugs in the elderly. Now, it has been shown that the TNF efficacy is similar, but when we say similar, we're talking about this, the DAS28. When you talk about the functional status, there is a very big gap between managing an elderly onset rheumatoid arthritis and a young onset rheumatoid arthritis. They will achieve the DAS28, but they will still be low on the functional parameter. And in fact, they looked into, let's categorize them into rapid responders, slow responder, or non-responders, and they did exactly the same when it comes to the DAS28 and the CDI and the SDI. They did exactly the same as the young. So it's a matter of functionality rather than actual objective evidence of disease activity. Interleukin-6 inhibitors, despite the level that is higher, when you see the tocilizumab effect, it's actually lower. So the older population, the less likely you will have a good EULAR response. But when you do have a response, the trend in drop in the CDI, SDI, or DAS28 is actually more with the increasing age. We do have evidence that going into remission with rituximab is less likely if you're above 75 years of age. And when it comes to JAK inhibitors, it's not a matter of efficacy, but rather a matter of safety. We have evidence, in addition to herpes zoster, that the MACE and the cancer is more common with the elderly. And again, these are elderly populations with RA and not elderly onset RA. And when we manage an aging population, remember that there are other concerns other than the medications and the choice of medications. There is the concept of the 5 M's of aging. It was previously the 4 M's. But when you manage an elderly, you have to think of mind, mobility, medications, what matters most to the patient, and the multi-complexity in the nature of managing them. And that simply means that in addition to managing the disease, you have to take into care depression, dementia, and their chronic pains. You have to remember fall prevention, optimizing muscle strength and endurance. And remember when you are adding medications that you have to tend to de-prescribe rather than prescribe. You tend to remove the medications that the patient needs less because you want to improve compliance to these medications. And managing a geriatric patient cannot be done without a geriatrician, a psychiatrist, a physiotherapist, so it's not simply a one-man's job. And always remember what matters most to the patient. Patients have concerns. They might miss your appointment because they have someone at home to take care of, or they have other concerns. They have another elderly to take care of. So you have to remember to support your patient as well as their caregivers. The concept of geriatric syndromes is known to most of you in the room, and we have to take care of two specific things as a rheumatologist: sarcopenia, which is a reduction in the muscle mass as you age, and then frailty. And in simple words, frailty means your ability to rebound after trauma. How a kid, for example, falls down the stairs and then comes again running down the stairs, as compared to an elderly who slips and then takes care the minute he goes down that he doesn't want to go down the stairs again. Because all these will add to the functionality, they will add to fracture risk and mortality and morbidity. As rheumatologists, we have to fight against ageism. We have to stop treating a patient just because he looks good for his age, or that's enough for his age. And we have to support the journey of our older adults and develop care interventions that are actually proactive rather than reactive. So with all those challenges, should we still aim for treat to target in the elderly onset rheumatoid arthritis? And the answer is yes. Because if we do, we're improving not only all the disease measures, including the HAC, we're actually reducing the dropouts and the side effects. And so the take-home message from the presentation is that to remember that Elderly onset rheumatoid arthritis patients often experience higher disease activity, more disability, and that comorbidities are a major effect on the outcome of the patients. Managing those patients should be considered on both the effectiveness and the safety of medications. Geriatric syndromes should not be overlooked, and as the aging population increases, we have to make efforts to enhance their medical treatment further. And in fact, let's do studies that focus on elderly onset rather than young onset rheumatoid arthritis. Thank you.
Thank you so much, Dr. Manal, for nice overview of this, often less kind of estimated topic. Our next speaker is Dr. Naif Al-Ghanim. Dr. Naif Al-Ghanim is a consultant rheumatologist at King Saud Medical City Health Cluster 1 in Riyadh. And he is going to give us a capsule, tough job though, about ACR, latest ACR convergence. So Dr. Naif, the podium is yours.
Okay. Just a moment, I'm waiting for them to upload it for me in the slide so I can see it. Anyway, good morning. So today I'll talk to you about the best of ACR 2024 rheumatoid arthritis. So I will share with you some of the abstracts that were presented in the ACR 2024. These abstracts were presented between November 14 and November 19 in Washington, D.C. So there will be 5 lessons that I'll share with you today, 5 important lessons for rheumatoid arthritis. Lesson 1, it's safe to use TNF inhibitor in rheumatoid arthritis patient with solid cancer. So it's a common scenario that we face in the clinic, a patient who has RA and uncontrolled rheumatoid arthritis, and patient is not responding well to methotrexate, and the question the patient has a history of cancer, either past medical history or recently diagnosed with RA or with cancer, and the question whether it's safe to use TNF inhibitors in these patients. So this is a retrospective study that included RA patients with early stage colorectal, lung, and prostate cancer. They look at the overall survival and disease-specific survival comparing TNF inhibitors versus conventional DMARDs and TNF inhibitors compared to no conventional DMARD. The overall survival was defined as the time from cancer diagnosis to death from all causes, and the disease-specific survival was defined as the time from cancer diagnosis to death from cancer diagnosis. So the majority of patients had prostate cancer, about 20%, about 15.6% had colorectal cancer, and 11.8% had lung cancer. As you can see, there was no worsening of mortality with TNF inhibitor treatment during the first, second, and third year of treatment. The overall survival and the disease-specific survival was the same. Actually, when you look at the overall survival, TNF inhibitor may actually improve the overall survival in these patients. Sorry. The same result was observed with patients with lung cancer and prostate cancer. Again, there was no worsening of survival in patients taking TNF inhibitors, and it didn't matter whether the dose was high or lower dose of TNF inhibitors. And what's interesting that the steroid was the only treatment that worsened the overall survival. So what we can conclude from this abstract that TNF inhibitor did not worsen the overall survival, and the only medication that we have to avoid in these patients, in those who have ongoing cancer or past medical history of cancer, is a steroid. Lesson 2, seronegative rheumatoid arthritis may not truly have rheumatoid arthritis. This is a study that was conducted in Mayo Clinic, and they looked at the switch in diagnosis of seronegative rheumatoid arthritis. They followed the patients for 10 years. They also look at the drug-free remission and the initiation of biologic and synthetic DMARDs in these patients. They included 176 patients with negative rheumatoid factor and anti-CCP. All patients met the 1987 and the 2010 ACR criteria. When they follow the patient for 10 years, 20% of seronegative rheumatoid arthritis turned to be not actually having rheumatoid arthritis. The most common switch of the diagnosis was spondyloarthritis, followed by seropositive rheumatoid arthritis. Other diagnoses included osteoarthritis, crystal-induced arthritis, and connective tissue disease in these patients. The 10-year cumulative of incidence of drug-free remission in seronegative rheumatoid arthritis was about 27%, and the 10-year incidence of using biologic or synthetic DMARDs was about 19%. Other studies actually found similar finding. There is, in this study that was published in 2019, 45% of seronegative rheumatoid arthritis tend to be, actually they don't have rheumatoid arthritis. The majority of the switch in diagnosis was spondyloarthritis, followed by PMR and osteoarthritis. Common type of spondyloarthritis, followed by axial SpA, then inflammatory bowel disease, rheumatoid arthritis. So the lesson that we have to get from this abstract, that we have to always reevaluate patients who were diagnosed with seronegative rheumatoid arthritis. In my clinic, personally, I found a lot of patients who were diagnosed with seronegative rheumatoid arthritis actually have osteoarthritis. Lesson 3, methotrexate does not increase the incidence of ILD in RA patients. Actually, methotrexate may protect against ILD. This is a systemic review and meta-analysis which look at the incidence of ILD-related rheumatoid arthritis in patients taking DMARDs. It included randomized control trials, observational trials, post-marketing surveillance studies, and out of 3,100 studies, 40 articles were included. Most of these articles examined the incidence of RA-ILD in biologic DMARDs, 21 studies, mainly TNF inhibitors, and 15 look at conventional DMARDs. 13 out of 15 were looked at methotrexate. So when you look at this force plot diagram, you can see that methotrexate was not associated with ILD, but actually also protective against ILD in the randomized controlled trials and observation trials. The odds ratio of ILDs in patients taking methotrexate was low, 0.48. When you look at the tofacitinib, there was no association between tofacitinib with ILD in the randomized controlled trials. In the cohort study, tofacitinib was protective against ILD. So what we can conclude from this study that there could be a potential role for methotrexate and tofacitinib in incidence RA-ILD risk. So we don't have to be scared if we have a patient who's taking methotrexate and they develop ILD while taking the medications. So why did earlier studies suggest a link between methotrexate and ILD? First, RA itself is associated with ILD. There's about 7 to 10% who develop symptoms secondary to ILD, and 67% who have radiological evidence of ILD. Second is that recent studies suggest that methotrexate may not cause ILD, but rather is given to patients who already have ILD. So this explains why previous studies warned us about the risk of ILD in patients taking methotrexate. Lesson 4, anti-obesity medication reduce joint pain and acute phase reactions in RA patients. A common question by patients who visit the clinic is whether it's safe to have bariatric surgery or take anti-obesity medications while they take other medications. Actually, they sometimes ask us to prescribe anti-obesity medication for them. Before going to the abstract, this is a study which looked at the prevalence of weight-lowering drugs intakes among Saudi females. It's about 21% of female take weight-lowering drugs, and this was 2020. I'm sure the prevalence is higher these days. And the two most common medication taking were Ozempic and Mounjaro, to the point that it's very hard to get from the pharmacies. So in this abstract, it's a retrospective cohort study. They included patients who were prescribed semaglutide, Ozempic, or tirzepatide, Mounjaro. 152 of 554 RA patients were taking anti-obesity medication. Unfortunately, there is significant incomplete data looking at the disease activity RA outcomes. This is the characteristics of the patient, and you can see that the disease-related comorbidities was very high. Dyslipidemia was 60%, diabetes 51%, hypertension 56.6%. Other comorbidities included obstructive sleep apnea, non-alcoholic fatty liver disease, polycystic ovarian syndrome, and coronary artery disease. So the anti-obesity medication helped to decrease the pain score over 12 months of treatment, and it also decreased the ESR and the C-reactive proteins. So how did these medications help to decrease the inflammatory markers in these patients? The GLP-1 inhibitor has direct effect over the nuclear factor kappa alpha light chains, which has anti-inflammatory effects by reducing the TNF inhibitors, interleukin 8 and interleukin 6, which finally leads to decrease in inflammation in addition to decrease the body weight. So it's safe to use anti-obesity medications in patients, and in these medications actually may lower the inflammation and lower the joint pain. The final lesson from the last ACR is that ACPA-negative rheumatoid arthritis disease can be prevented by 1-year course of methotrexate. There are 5 stages to develop rheumatoid arthritis, going from the bottom to top. First, the patient should have a genetic and environmental risk factors for RA. Then they develop systemic immune dysregulation, followed by symptoms without clinical arthritis, then unclassified arthritis, and finally, rheumatoid arthritis. In this abstract, they included patients who have symptoms without clinical arthritis, and actually, most of the studies included stage 3 of in these patients. So they included patients who have clinical suspect arthralgia, which was defined as a recent onset of arthralgia within 1 year, and other causes of arthralgia were excluded. They also included patients who have MRI evidence of subclinical inflammation. They conducted MRI of MCPs, wrist, and MTP joints, which showed synovitis, tenosynovitis, and osteitis. They stratified patients into low risk, increased risk, and high risk. Low risk included patients with arthralgia without MRI evidence of inflammation. Increased risk are patients with arthralgia and MRI evidence of inflammation, but they were seronegative. And the high risk are patients with arthralgia, MRI evidence of inflammation, and they were positive to either rheumatoid factor or anti-CCP antibodies. It's a double-blind, placebo-controlled trial. It included 182 ACPA negative patients and 54 ACPA positive patients. The study was conducted between April 2015 and 2019. All patients received 1 dose of IM steroid. 119 patients received methotrexate up to 25 milligram per week, and 117 patients received placebo. When you look at the increased risk group, methotrexate decreased the risk of developing rheumatoid arthritis. In the treatment arm, only 8% develop ACPA-negative rheumatoid arthritis after 4 years of follow-up, and in the placebo group, 29%. In the low-risk group, there was no difference between the methotrexate and placebo. In addition, in the ACPA-positive group, there was no effect of methotrexate in preventing the development of rheumatoid arthritis. So this is the first evidence that a medication can prevent the development of rheumatoid arthritis by using a 1-year course of methotrexate. Previous studies failed to show similar results. In this study, they used multiple medication, including dexamethasone, rituximab, atorvastatin, Plaquenil, vitamin D, and abatacept. The issue with these medications that they focus on medication that we use to treat rheumatoid arthritis rather than preventing rheumatoid arthritis. So these medication jobs is to reduce inflammation rather than prevent inflammation. Their effectiveness in preclinical phase is uncertain. We need medication that can reverse or reprogram immune process rather than decrease the decrease the inflammation. We need to know how to restore immune tolerance and correct early disturbance, and by doing that, we can identify therapeutic targets that have a potential role to prevent rheumatoid arthritis. The only 2 treatments that can restore or reverse the immune system that we have today are bone marrow transplant and CAR T cells, which are expensive and associated with multiple side effects. So the final key message, TNF inhibitor is safe to be used in RA patients with solid cancer. The diagnosis of seronegative rheumatoid arthritis should be re-evaluated at every clinic visit. Methotrexate and tofacitinib may offer protective effect against RA-related ILD. Anti-obesity medication may reduce joint pain and lower acute phase reactant. And finally, a 1-year course of methotrexate may prevent the onset of ACPA-negative rheumatoid arthritis. Thank you.
Okay. Thank you so much, Dr. Naif, for this nice overview of the RA sort of new insights from the last ACR 2024. Now it's the time for panel discussion, so we'll open the panel for questions, comments.
Thank you for all speakers. Excellent presentation. My question to Dr. Naif. But in the guidelines, still we have no clear about safety for especially anti-TNF in a patient with solid cancer. They still, in their recommendation, that the anti-TNF and biologic in a solid tumor should be held at least 3 years. Yes, there is a case series, some meta-analysis showing the safety of continuity and the remission even on the cancer patient on treatment. But the guidelines still did not change.
Yes.
And my second question about other biologics, which is really surprising, that maybe other biologic is less, strictly not to be given in solid, while the other, while anti-TNF is the most, medication that is not to be given, especially in those patients.
Yes. All the previous studies were controversial with their TNF inhibitors is associated, or methotrexate associated with cancers or not. In the ACR, I think before 2015, the ACR recommendation was to hold or not to use biologic for 5 years. In the last EULAR, I believe, or the ACR, they said that we can, before starting biologic DMARDs, the decision should be shared with the oncologist, and we should assess the risk of developing cancer. My experience when I call oncologists, some of them, they don't have any problem. I have patients with prostate cancer, and they say, when I ask them whether it's safe to give TNF inhibitors, they say it's okay. And another patient who have breast cancer and metastasis, another oncologist say he advised me not to use biologic. I still follow their recommendations, but I think our rheumatoid arthritis, especially uncontrolled rheumatoid arthritis, should deserve to be treated very well. Especially like the patient that I have, breast cancer, metastasis, she's stage 4, she deserves to be treated very well. Especially that the studies are controversial, and recent trials are reassuring that biologic or TNF inhibitors, even methotrexate, are not associated with cancer. I remember the only cancer that might be increased are the non-melanoma skin cancers. These are the maybe increased with biologic or methotrexate, but other cancers are very controversial. So my advice is to discuss the biologic medications with the oncologist before starting it in patients with cancer.
دكتور هنا.
There is a mic.
Yes.
On your back.
Hello?
He's first, دكتور معليش.
Thanks, Dr. Ghanem. Regarding methotrexate for seronegative arthralgia, just correct me, do you mean that risk stratification, the second and the third, these deserve to start on methotrexate? Or the second one? Because seronegative mean the risk stratification number 2.
Yes.
Is that right?
Yes.
So this is the seronegative with evidence of synovitis on MRI.
Yeah.
Is that right?
Yes, it's a very good question whether we should apply to it. I think it's very early to apply to start methotrexate in these patients. This is just a study that may guide us in the future and what should we do in these patients. My impression, if the patient has arthralgia and there is evidence of inflammation in the MCPs joints, this is inflammatory arthritis. I'll treat them as inflammatory arthritis, as undifferentiated inflammatory arthritis. But the question is, should we treat all patients with arthralgia with methotrexate to prevent rheumatoid arthritis? Is no.
No, yeah,
no.
that's right.
Yes, because
so in
yes.
real life, we can say if you have arthralgia with no evidence of clinical synovitis,
yes,
and
I wouldn't give methotrexate.
And there is positive rheumatoid factor or anti-CCP, then you can start with something like hydroxychloroquine.
That's different.
No,
right?
the previous studies, the table that I showed that even Plaquenil did not prevent the development of rheumatoid arthritis.
All right.
The other question, there is no consensus in the definition of preclinical rheumatoid arthritis. In this study, for example, they include patients who have MRI evidence of inflammation. Other studies say no, only arthralgia and positive rheumatoid arthritis. What I do, if there is evidence of inflammation, I'll treat them as an MRI. I'll treat them as undifferentiated inflammatory arthritis, whether with Plaquenil or methotrexate. But if they don't have evidence of inflammation in MRI or ultrasound,
no indication.
I wouldn't treat them.
Sure.
Yes. Yeah.
Thank you.
Next.
Yes, please.
Yes.
Yeah. My question is to Dr. Manal. You mentioned already that pathogenesis of the elderly, it is more with the interleukin 6. Do you prefer tocilizumab rather than anti-TNF biologic medication in elderly?
Okay, so that's a good question, because if you ask about my personal opinion, you will find that most of our practice kind of reflects the Canadian practice. And we're similar to the Ontario registry in that in the elderly population, the best options or the most used option were actually etanercept and then followed by abatacept. And that's based on the safety profile rather than the utility or the activity or the efficacy of the drug. When you look at the Japanese population, you find that more of them are actually using more Actemra, and that's been shown to be increased in utility. So as the years progress, there is more and more use of IL-6 in that population. Just keep in mind that you might have a 40% chance of response and a 60% chance of no response, you would still have to cycle medications in those populations.
Okay. Last question, please, there, Doctora.
Thank you to all speakers. My question to Dr. Naif. If I have a rheumatoid arthritis patient with interstitial lung disease, can we start safely methotrexate?
Yeah, if the recommendation is that if patient has already on methotrexate and the patient has ILD and the ILD is stable, yes, you can continue methotrexate. The preferred medication to be used in these patients were rituximab and IL-17, as they may prevent the ILD. So what I do now is patient has RA and ILD and patient methotrexate doing well, I can continue methotrexate. If I think their ILD is worsened, I might choose IL-17 inhibitor, IL-6 inhibitor, sorry, or rituximab.
Okay, thank you.
Okay.
So we can continue methotrexate in patients with RA and ILD. Yeah.
As chairpersons, we're allowed to have one question. صح؟ So what about patient who has chronic arthralgia, who has high inflammatory marker and positive serology? This is probably easier than those who are seronegative. And they have evidence, clinically they don't have synovitis, but they have evidence of synovitis on an MRI, which is not operator dependent, so it's definite. Yeah. So probably that's easier sort of thing to go.
Yeah, I think we all have different opinions regarding these patients, whether they actually have inflammatory arthritis or not. I usually trust MRI than ultrasound. If the ultrasound tells me it's synovitis and I'm not convinced, I order MRI to see if there's inflammation. If the MRI is read by a musculoskeletal radiologist and the musculoskeletal radiologist that said that there is synovitis, I will treat them. Okay. Yeah, I'll treat them as.
What's the preferred agents? Would you abatacept would be the one, or?
In this study, the abatacept failed.
Okay. So seronegative.
Yes. So methotrexate.
Seronegative.
Oh, and seronegative. I don't remember the abatacept trial. I think there were 2 abatacept trials.
Yeah.
Both failed. Yeah. Yes. Yeah. Methotrexate, the only one, and it didn't work on ACPA positive. It worked mainly in ACPA negative.
Okay. Yeah. Thank you so much. We'll come to the end of this session. Thank you all the speakers.
Thank you.
And the organizer as well.
السلام عليكم ورحمة الله وبركاته. أسعد الله مساءكم بكل خير. الآن مع تكريم. Thank you for the speaker and for the chairperson. الدكتورة معتوقة. الدكتورة منال.
Ultra beats on the track.
طيب، الآن إلى توقيع اتفاقية بين الجمعية السعودية لأمراض الروماتيزم الجمعية الجلدية لأمراض أو الجمعية للأمراض الجلدية. الدكتورة دانا العيسى والدكتورة حنان الرئيس. أعضاء البورد إذا سمحتوا الموجود يتفضل عندنا. نايمين.
Ultra beats on the track.
السلام عليكم ورحمة الله وبركاته. طبعا الدكتورة دانا العيسى توقع on behalf of الدكتور عبد الله العقيل. هذا التعاون بين الجمعية السعودية لأمراض الروماتيزم والجمعية السعودية للجلدية وجراحة الجلدية، ومن ضمن التعاون حضور المؤتمرات المتبادل وما يقارب 50% خصم في حضور المؤتمرات سواء عندنا أو لديهم، بالإضافة إلى إن شاء الله الكثير من التعاون بين الجمعيتين. نسأل الله التوفيق إن شاء الله بإذن الله للجمعيتين. شكرا.
شكرا لك دكتورة حنان، وإن شاء الله الاتفاقية هذه تعزز بما يخدم الفيلد الروماتولوجي وفيلد الدرماتولوجي، تعاون في المؤتمرات، تعاون إن شاء الله في putting guidelines والخدمة المجتمعية والأبحاث، وإن شاء الله membership also benefits for both sides. يعطيكم العافية، بالتوفيق. شكرا.
الله يسعدكم. الحين بريك الغداء مع الصلاة، حنرجع إن شاء الله الساعة 1 exactly. في 2 lectures وفي الكلوزنج وفي جوائز، 3 جوائز من الحضور اللي هم أكثر ناس حضروا واستمروا إلى الأخير. فنشوفكم إن شاء الله هنا على الساعة 1. كيف؟ طبعا أهم شيء في الإيمج كومبيتيشن، وفي نحتاج تقييمكم معانا. حيكون رئيس الجلسة الدكتور وليد. تحب تقول لهم كم كلمة على أساس جس نتأكد حضور الجميع إن شاء الله؟
اللي بيفوز يقعد. لكن ان شاء الله باذن الله تعالى الايمج كومبيتيشن حتكون a little bit of exciting ان شاء الله this year، فننتظر حضوركم. اهلا وسهلا.
Today we present a
السلام عليكم ورحمة الله وبركاته.
This is a case of a
Assalamu alaikum. I want to share with you this interesting.
السلام عليكم.
Al-Hazmi, who's an internal medicine and rheumatology consultant, Deputy CEO at Prince Mohammed Medical City and Vice President of the Saudi Society of Rheumatology, and Dr. Hanan Al-Asaimi, who's a consultant and internal medicine and rheumatology and at King Fahad Armed Forces Hospital in Jeddah. Welcome.
Thank you for the introduction. It's my pleasure to introduce the first speaker in this session, Dr. Basma Al-Wahabi. Dr. Basma, consultant endocrinology at King Abdullah bin Abdulaziz Hospital and Princess Noura University. Dr. Basma, you are welcome. King Abdullah.
Okay, good afternoon, everybody. I know it's the last day and it's after lunch, so maybe you don't have a lot of energy to listen, but I hope you can focus. I would like first to thank the Society for inviting me and Dr. Hanan Reyes. So I will be a little bit quick because of the time. It's only 20 minutes, and the topic is big. So we'll talk about the current management and update guidelines in osteoporosis. I know that as rheumatologists, your main focus is on steroid-induced osteoporosis, but still rheumatologists, they treat osteoporosis, and there is a lot of shared aspects between the two. So I will focus on the osteoporosis medications, whom to treat, how to select medication, duration, when to stop, when to change, and when to restart. So whom to treat in general in osteoporosis, we treat patients who are high risk with low trauma fractures. We treat patients who have T-score less than -2.5 upon screening. We treat patients with osteopenia who reach the cutoff limit for treatment, and women with osteopenia if they have continuous bone loss. And of course, we'll not go through the steroid-induced osteoporosis. Just will give 2 slides at the end because it's a special topic. But anyway, we treat also patients who apply treatment according to the guidelines for GIO. So this is just table to summarize the indications for using medications in osteoporosis. Okay, so regarding osteoporosis medications, we know that we have 2 groups, the anti-resorptives, which inhibit osteoclast, and the bone-forming agents, which stimulate osteoblast. and will not go through the medications that are not available in Saudi Arabia or are not commonly used. So the bone-forming agents will stick to teriparatide and romosozumab, which is combined anti-resorptive and bone-forming agent. And the anti-resorptive drugs, which are subclassified into bisphosphonates, which includes alendronate and aclasta or zoledronic acid, and HRT if needed, if patients has hypogonadism or there is any indication for HRT, this is considered anti-osteoporosis medication, and denosumab. So before you deal with osteoporosis in general, you have to know everything about these medications, everything. So you have to cover their mechanism of action, their side effects, how to use them, the contraindications, the duration of use, a lot of things. And I mean, it's a lot of readings, but you can't deal with these medications unless you know every bit and piece of these medications. So for example, if patients have GI problem, I will not give alendronate. If patients has recurrent UTI, I will not give denosumab. If patients has chronic kidney disease, will not give bisphosphonates. Patients have bone cancer or received radiotherapy to the bone, we will not use teriparatide or in children. So there are very strict certain situations where it's contraindicated to use certain medications. Otherwise, usually if patients doesn't have any of these factors, okay, you can use any of the medications, but you consider other factors that we will talk about now. So you consider the patient preference. Some patients, they don't like oral treatment. Some patients, they prefer injections. Some patients not. If the patient has hypogonadism and they need HRT, I will not use the other medications. The severity and the site of osteoporosis, I need to know the effect of the medications on hips and vertebra. Any prevalent fracture, which means that there is severe osteoporosis, any medical disorders, renal cancer, as we mentioned, side effects and contraindications. So to start with, when you want to select medication, which one you will use? You will use anabolic or anti-resorptive? This is the first question that you have to decide for. The evidence shows that the best treatment is what we call sequential therapy, where you start with anabolic agent and you build up the bone, and then you continue with anti-resorptive. But the problem with this is that the anabolic agents usually are injectable, especially teriparatide is daily injections. Not everybody accepts this, and they are very expensive. And there is no head-to-head comparison between the two, teriparatide and the romo, to justify preferring one of them. So you can use any of them according to your availability. And recently there is people try to make it easy to people to select medication. So you use the patients with very high fracture risk, and those patients you will give them the anabolic agents. So the criteria is patients with recent fracture, patients who fracture while on other osteoporosis medications, multiple fractures, T-score less than -3 or some people -3.5. Patients on long-term steroids with very, very high risk of fracture, patients with very high risk of falls, and patients with very high risk of fracture according to the FRAX tool that exceed 30% or 4.5%. And we use anabolic agents, especially teriparatide in some situations, but it's not approved for that, but people commonly use it, and there is a lot of evidence that they are useful, like in atypical femoral fractures, delayed non-union of fracture, or individuals with very, very high risk. When you start the treatment with any of these medications, how do you monitor therapy? You monitor therapy by repeating DEXA scan every 1 to 2 years, not before that, and you give the drug for the whole course of the duration of the drug. Sorry, I have flu. So you continue the full duration, which is different between medications, unless the patient develops side effects or they have poor compliance or they fail therapy. So how do we define failure of therapy in these patients? The general agreement is that failure of therapy, if the patient's fracture after the first 6 months of treatment, if they have change in bone density that exceed the LSC, which is the least significant change. Thank you very much. So if the patient change in bone density or the decline in bone density exceeds the LSC. What is LSC? This is the least significant change. And this is the change that, what we mean is that when you do a scan for a patient and after 1 or 2 years you repeat the DEXA scan, then of course it will give you different results. So there is some accepted error in the machine or accepted change in the result of the DEXA scan. So the accepted result should come to you as LSC. So if the LSC is more than 4%, usually it's more 4%, this is not acceptable. If there is decline of more than 4% or 3.5, depending on your center. If it exceeds that, this change is not, or this difference is not acceptable. And this means that there is failure of therapy, so you have to review with the patient. Maybe it's compliance problem, maybe it's just biological failure, and you have to change the medication. So the stopping or continuing medications has its pros and cons. And this is why, people, they decide to give bisphosphonate 3 or 5 or 6 years, for Aclasta or for alendronate 5 to 10 years. This the choice of which one to use, how to extend the medications, depends on the pros and cons of continuing or stopping medication. So for example, if you continue alendronate for more than 5 years, there is decreased risk of clinical vertebral fracture, but not of non-vertebral fracture. If you continue more than 5 years, alendronate or Aclasta 3 years, you have a risk of atypical femoral fracture, which is very nasty fracture, and it's special for these patients. If you continue, if you stop denosumab after any time, 2, 3 years, 4 years, 6 years, you will find there is a sudden drop in the bone density, which is very sharp and very dramatic in very short time. And if you restart the medication, again, the bone density, it will increase again quickly because it's short-acting medication. So this means what? That you can't stop denosumab. However you use it, for how many years, you can't stop it because you will have bone loss after that. And we saw the result with the evidence that there is what we call rebound vertebral fracture after stopping denosumab, which can be even lead to multiple fractures. It's worse than the risk before the treatment. I saw 2 patients who fractured because they delayed their injection for only 2 or 3 months. So they had vertebral fracture. So be careful of this. Always make sure that the patient knows that they should come back after 6 months. If you give teriparatide, if you stop, all the bone that is gained during treatment, it will be lost. So you can't stop medication without giving something else. So the general guidelines for the duration of treatment is that after bisphosphonates for 3 to 5 years, which is either Aclasta 3 years or alendronate 5 years, you reassess. If the patient is high risk, you assess by looking at the age of the patient, history of fracture, the DEXA scan result. If the patient still has high risk of fracture, you can continue for 6 to 10 years. If the patient has moderate risk or doesn't have any of the high risk factors, you will consider drug holiday. When you start a drug holiday, you have to monitor the patient and you have to reinitiate treatment, whether the same drug or any other medication, but you have to reinitiate any treatment if the patient fractured during a drug holiday, if they have bone density loss of more than 4% at any site. Okay, so this is usually the course of the treatment when you are following these patients. Even if you give for steroid-induced osteoporosis, you follow the same steps here for the treatment. And this is just to summarize the steps of the treatment. And of course, as we mentioned, after teriparatide or denosumab, because there is bone loss, you don't stop treatment. Usually, you have to follow with another treatment. So either you give denosumab for like 10 years, which is the allowed duration, and then you reconsider after that what to do. Teriparatide, you can give it up to 3 years, but after that, you have to give anti-resorptive immediately after you stop it. What you need to know when you are dealing with osteoporosis is that there are baseline DEXA report minimum requirements. So you always have to communicate with your clinical densitometrist or radiologist in the hospital to make sure that all this in detail is put there, especially the LSC. Not every hospital, they do calculation of the least significant change when they do serial DEXA scan for patients. And this is regarding glucocorticoids. It's a lot of facts regarding the GIO, but because I thought you are a rheumatologist, this is your main interest. How to deal with GIO, how to adjust fracs in these patients. You have to adjust according to the duration or the dose of steroids. In the past, the fracs tool just included use of steroid without focusing on the duration or the dose, which we know is not practical because there is a lot of impact depending on the dose of steroid that is used in the treatment. So now you can adjust it by increasing the risk or decreasing it. Now regarding the GIO, just 2 slides about that. So the first thing you do is risk stratification of the patients, whether they are low, moderate, or high-risk patients, depending on a lot of things, mainly the age, which is the cutoff is 40 years of age. So, and the result of the DEXA scan. And of course, if it's less than 40 years, you go for the Z-score. So the risk stratification. And then when you decide or when you stratify the patient into which risk, then you will treat. So you will treat patients who are younger than 40 years, who have high risk of fracture, and patients who are more than 40 years, who have moderate to high risk of fracture. Regarding patients who are more than 30 years receiving high dose of steroid or a cumulative dose of more than 5 grams in 1 year, probably you need to treat these patients just as a prevention. And then again, what you use is usually recommended is oral bisphosphonates or IV bisphosphonates. Then the following choice is teriparatide because of the expense, and then derazumab. So bisphosphonate, usually they have the highest evidence of proof in GIO. Again, this is just to summarize this. Okay, now regarding vertebroplasty and kyphoplasty, I'm sure that you see a lot of patients with fractures, especially patients who, with rheumatoid arthritis on steroid. They are the highest risk among all rheumatology patients. So if you hear or you see or know about vertebroplasty, what you need to know is that there is no good evidence that it works. Usually they tried people in the past to maintain the vertebra and to decrease the pain, but there was risk of fracture also because of the procedure, even of the adjacent vertebrae. So now people are not using it anymore so widely. I mean, I saw one patient which she had it and she fractured the next vertebrae, the adjacent vertebrae to that. So probably there is no strong evidence to support using it in patients with the fractures. Thank you.
Okay, thank you, Doctora. And imaging assessment. So, Dr. Mamdouh, please.
السلام عليكم ورحمة الله وبركاته. مساء الخير جميعا. I'm Dr. Mamdouh Malki, consultant of intervention, diagnostic intervention musculoskeletal radiology, head of musculoskeletal radiology unit in King Khalid University Hospital and King Saud University. My topic today is axial spondyloarthritis and imaging assessment. First, this is the objective of this lecture, highlight on the image findings on axial SPA and closing spondylitis. Differentiating of the image finding between the axial SPA and axial psoriatic arthritis, update about the various disease entities and conditions that may mimic axial SPA and how to differentiate among them. The fourth point is quick review about the challenging encounter in our practice. So, spondyloarthritis comprises of group of chronic inflammatory rheumatic disease, including ankylosing spondylitis, reactive arthritis, and spondylitis associated with inflammatory bowel disease, psoriatic arthritis, as well as undifferentiated type. These afflictions predominantly affect the axial skeleton, causing pain and stiffness. And they are seronegative for rheumatoid factors and are often associated with the presence of HLA-P27. They are largely differentiated on the basis of clinic and radiographic abnormalities. The sacroiliac joint are involved in the most cases of axial SPA, with sacroiliitis usually being the first manifestations. The imaging modality, radiographic, is used in the established classification criteria, such as modified New York diagnostic criteria for ankylosing spondylitis, rely on the combination of clinical symptoms and definite radiographic finding of the sacroiliitis. However, conventional radiographic are usually normal at the onset of the symptoms, and the diagnosis is commonly delayed by 8 to 11 years. Can I use the pointer here? The first, this is a grading of the sacroiliitis grading system, New York criteria. If you see the first image, this is a grade 1, normal sacroiliac joint outline. There is no subchondral sclerosis. The space of the joint itself is normal, and there is no erosion. So we don't have any suspicious findings here. This is X-ray for the normal sacroiliac joint. Grade 1, we cannot say this is a normal sacroiliac joint, but there is no suspicious findings. So the first definition of this changes is ill definition of the sacroiliac joint. Usually this is the earliest sign can be detected on radiographic studies, which is called blurry margin, which is suspicious here. Grade 2, we have localized changes and minimal change in the sacroiliac joint. However, it's not extend to all the portion of the joint, as well as there is a preservation of the joint space. So grade 2, we have preservation of the joint space. There is no narrowing. Grade 3, we start to see advanced disease. And for sure, this is abnormal. And there is a lot of erosions, a lot of sacroiliac subchondral sclerosis, a lot of joint width change. So there is change in the joint space. The last group, our last grade, is the grade 4, which is almost there is fusion of the joint. Okay? For MRI, the new assessment of the spondyloarthritis Internal Society AS criteria, which include the MRI imaging finding to facilitate the early diagnosis and assessment of the treatment response, because the capacity of this study to help predict the active or early change in the bone marrow. So with MRI imaging, spondyloarthropathy can be diagnosed and treated in the early stage if you compare it to the X-ray. If you use X-ray alone before structural damage occur. MRI is now one of the cardinal tools for diagnosis sacroiliatic associated with axial spondyloarthropathy, because it allows assessment of the active inflammation changes. If you compare it to the X-ray, this means that MRI imaging can show incipient changes in the cartilage and acute inflammation activity in the subchondral bone, in the ligament, synovial capsule region. So in addition, the MRI imaging has a similar sensitivity to CT scan to detect the early structural damage and better for fatty deposit assessment or detection. And unlike CT, it involves no radiation exposure. As you know, the main limitation of MRI imaging are mostly related to ferromagnetic implants, cardiac pacemakers, and claustrophobia. The protocol of MRI in all the most of institution or the basic protocol should be planned with the long axis of the sacroiliac joint, not the straight to the not the straight or long axis for the spine. So should be obtained on oblique view. This number one. Number two, we have a basics two important sequence here. The sequence number one is the is designed for the structure detection or structural damage, which is a T1. The second important sequence is fluid-sensitive sequences. Fluid-sensitive sequences include STAIR, include T2 FATSAT, or any sequence that detect the fluid here. So to detect the synovial change, the capsulitis, the subchondral edema, and inflammation. These are the basics. We can add more additional sequences, especially for monitoring the disease, or if you have equivocal question about the change in the behavior of the disease in the second or next follow-up, such as giving contrast to the MRI. It will give sometimes a hint there is increase or decrease response. And there is also additional sequences like gradient, weight diffusion sequences. It may help, but it's not usually included in the basics of imaging MRI for sacroiliac joint or spine. So X-ray in general serves as the initial image modality, often non-specific, and it's appear normal in the acute stage. Ultrasound here useful for detection the collection and fluid around the joint, especially if the case is septic, not inflammatory disease. CT scan, usually if we have a question mark about the erosions, or pre-op assessment, but for nowadays, MRI can show with X-ray the erosion, even if it's small. So here the MRI reveals the soft tissue inflammation along the alteration on the bone marrow. So we have the soft tissue inflammation, joint effusion, synovitis, capsulitis, enthesitis, and chylosis. And the structural damage, including the erosive changes, subchondral edema, subchondral enhancement, and subchondral fatty deposition or subchondral sclerosis. So the structural changes and signal change are very important markers for us in MRI assessment. This is a very important slide. If we start from the superior part of the joint, this is oblique view. As we mentioned before, we take all the image in oblique view. This is the superior part. A is the superior part of the joint, which is the superior 1/3. Second one is the second third. The third one is the third section. The superior one, if the disease is involved, the anterior part is more suspicious if it's more than the posterior part. At the second portion, the synovial usually located at the anterior part of the joint, but we have other mimickers like degenerative disease here. The inferior part, if you have erosive changes, subchondral edema, subchondral sclerosis involving the inferior part, here we can say this is suspicious. So Imaging of findings of axial SPA and closing spondylitis. We have active inflammation lesions, as we mentioned before, and chronic or structural lesions. The active inflammation, including the bone marrow edema, synovitis, capsulitis, enthesitis, and visualization usually on STAIR or T2 FAT-SAT or contrast-enhanced studies. The chronic or structural changes are usually will depict on the T1 weighted images. Include the subcondylar sclerosis, erosions, periarticular fat changes, and ankylosis. So this is a radiographic frontal view for the spine and sacroiliac joint. Shows, as we see here, bilateral erosive, almost symmetrical, more on the right side, and combined with subcondylar sclerosis. As well as there is symmetrical peripheral syndesmophyte or ossification of the spine, give appearance of bamboo spine. So this is a radiographic finding of the axial SPA. The second X-ray shows almost similar changes, but less extensive. It's bilateral, symmetrical. If we see the joint from the superior to inferior part, it's mainly predominantly affect the mid lower two-thirds of the joint. This is a smooth symmetrical syndesmophyte called, the sign is called bamboo spine, and there is ossification of the interspinous ligament. Do you have marker here to show you that? Can you go back? Okay, it's okay. So if you see the interspinous process, there is ossification between the spinal process and give the appearance of dagger sign. So this is one of the sign of ankylosing spondylitis. And facet joint fusion or ossification also give the appearance of tram track sign if we see it on frontal X-ray. This is another example for advanced stage of ossification that associated with advanced disease of ankylosing spondylitis. The facet joint here almost fused, and sacroiliac joint here also completely fused. So this is grade 4 according to New York criteria for radiographic assessment of the sacroiliac joint. This is we can say not advanced stage of the disease, but it's considered one of the radiographic changes that associated with ankylosing SPA. If we see the superior aspect or anterior superior aspect of the vertebral body, we can see the area of sclerosis or area of ill definition of the bony cortex. So this is called corner erosions, Romanus lesions, or Chiney corner. In advanced stage, osteopenia is one of the radiographic signs, and there is a risk of fracture for sure. The MRI findings, include the bone marrow changes and also the soft tissue changes. If we are talking about the bone marrow, we mean the most important landmark findings here is bone marrow edema. If we see here, there is a subtle subcondylar bone marrow edema, bilateral, almost symmetrical. And there is small erosions on the right side, and surrounded by small area of bone marrow edema. And also on fatty suppression sequences, sometimes we cannot see the subcondylar sclerosis, but Subcondylar sclerosis can be also as same as the subcondylar fatty changes. However, T1 images here will help. If you see the most inferior part of the joint here, just inferior to the joint, right sacroiliac joint, see the attachment of the muscle there. There is sign of enthesitis and capsulitis on the right side. On the right lower third is very subtle. So MRI can detect early stage of non-radiographic findings. As you see here on the left side, at the attachment of the gluteal muscles, there is subtle edema. Okay. There is a subtle edema in the left gluteal maximus attachment. So it's a sign of enthesitis. Here the stair shows edema within the right sacroiliac joint, so it's called effusion. But if you give post-contrast images, you will see the hyper-enhancement post-contrast, and the effusion or high signal intensity on a stair on the right sacroiliac joint is not enhanced, so it's fluid. But the area around the joint here is enhanced, so this is active disease, or still there is hyperactivity. Structural damage, you will see the changes bilateral. As we mentioned before, if you see the left sacroiliac joint, there is increase of low signal intensity on a stair, but on T1, it's high signal intensity. So this means not subcondylar sclerosis. This is T1 fatty deposition disease. So this is a chronic process or almost healed. This sequence shows this is a coronal T1, and the second one is a stair. It shows ossification bilateral sacroiliac joint, and there is no joint space, and replaced by area of high signal in T1. So this is yellow marrow, so this is ossification. So almost the joint replaced by osseous fusion. So this is a case of ankylosis on MRI, and it's very clear for us on X-ray. This is the shiny corner, our enthesitis at the attachment of the end plate, as we previously see it on the X-ray. This is appearance of disc ossifications. So the disc is replaced by bone marrow changes. And distal lesion also, this is not septic. We have differential diagnosis with the infectious spondyloarthritis. Can you go back, please? Distinguishing the imaging characteristic between the axial SPA and axial psoriatic arthritis, usually the axial involvement in psoriatic arthritis usually is extensive, unilateral, and asymmetrical than the sacroiliac joint that involved in the axial SPA. And usually there is not less frequent to be complete ankylosis, and the syndesmophyte is bulky and chunky, and usually it's paramarginal, but it's not like osteophyte at the margin of the joint space.
Dr. Mamdouh, 2 minutes.
Yeah. So this is an example for the syndesmophyte. It's marginal, skip vertebral levels. This is less bone marrow edema, usually with psoriatic arthritis compared to ankylosing spa. This is extensive but usually asymmetrical. So the entity that be included in the differential diagnosis, including the inflammatory bowel disease, degenerative disease, infectious process of the sacroiliacal spine, also osteitis and condensus ilii, show symmetrical bilateral subcondylar sclerosis, but there is no significant erosion or edema. Also anatomical variations and insufficiency fractures, modic changes, and dish. Usually there is preservation of the discs, and there is no erosive changes. And also the facet joint here is abnormal. Or sometimes hyperpara subcondylar. So I think this is the last slide shows the most important challenges that we encountered in diagnosing the axial spine MRI. Patient contraindicated to MRI, technical issues, a lot of motion artifact. We cannot see the joint clearly. Background of affected joints, differential diagnosis with other mimickers, and very early stage of MRI findings, also behavior of the disease that not involve the sacroiliac joint in the first line. Thank you.
Thank you, Dr. Mamdouh. So thank you both for Dr. Basma and Dr. Mamdouh for this informative presentations. Now the floor, we'll open the floor for discussion and questions, please. Dr. Ahmed.
Thank you so much for this nice overview with speakers and chairperson alike. My question for Dr. Basma. Now we know this rapid gain, rapid loss about denosumab. And we always say maybe 3 weeks is the kind of time frame, so not to miss the next dose beyond 3 weeks. You know, it's quite expensive, and despite being convenient, but it's quite expensive, and some patient may come late, months later, and we realize that they did not get the dose because they could not find it or they cannot afford to buy it. Now, to prevent the potential rapid loss and subsequently fracture or osteoporotic fracture, with just reinstitution of denosumab would be enough, or you might choose a more potent anabolic rather than thing. Someone who missed denosumab, and it's been now a few months later, beyond the 3 weeks time limit, I would say, and so in an effort to decrease the potential fragility fracture, would you reinstitute the denosumab or choose a more potent one to regain the what's lost that quick in denosumab thing?
Okay, thank you for the question. So the question is, if a patient, like, they are late for their dose of denosumab by 2-3 months, and you are afraid of vertebral fracture, would you go for more potent medication like teriparatide? First of all, there is no evidence to show this. Personally, I don't think it will work, because if you give teriparatide, it needs 6 months to start working. Okay, so anyway, there will be a risk of fracture. Starting it will take more time. It's better to give the denosumab because it's short acting. If you give it, it will start acting now. But from the start, usually I prefer to go for Aclasta. If you have it, I always go for Aclasta first, unless it is unavailable. If it's, or there is like CKD, significant CKD. Because I know Aclasta is once a year, and even if the patient is late by 2 to 3 years, we know that there is retention in the bone, and there is no risk of refracture. But sometimes, like in my hospital now, we don't have Aclasta for about 1 year now, so we are stuck with denosumab as anti-resorptive. But if the patient is late, I will not go for teriparatide because of the window of 6 months. Okay, I will give denosumab and ask the patient or educate the patient that they shouldn't be late. and you harbor the risk, what you can do.
Yeah, of course, we're addressing postmenopausal osteoporosis for discussion. My other question, and last question from my side for Dr. Malki. I didn't see any comments on SPARC scoring system for sacroiliitis. As you know, there false SPARC scoring system for sacroiliitis. As you know, there may be some sort of false positivity in certain bone marrow lesions. It's been seen in healthy people, in athletics, and patients with mechanical back. So I didn't see no comments on SPARC scoring system.
As you mentioned before, the subcondylar edema is the most hallmark findings we can mention here, and it's important to correlate every patient we receive in according to any score system. The bone marrow signal here is very important for us to mention in the report, or to give a hint for the referring rheumatologist about it. And for sure, we have to correlate the background of the clinical data about the patient age and other patient age, inflammatory back pain, and any labs, any positive lab findings. So it's important for us not scoring every patient with any score or any score system here, unless we have to correlate clinically, as you mentioned.
Any further questions?
Thank you for all the speaker, and thank you for the attendees. And now we conclude this very nice, session. Thank you.
شكرا.
دكتور منصور العازمي. دكتورة حنان العسيمي. دكتور ممدوح المالكي. Okay, our next session is images competition, will be chaired by Dr. Walid Hafid. Welcome, Dr. Walid.
Is it working? Yeah. Assalamu alaikum wa rahmatullahi wa barakatuh. So finally, it's that time of the year, and it's that time of the conference that everyone is still here because they think that they might win at this image competition. So for the second year in a row, we're very happy to introduce this image, competition contest. The difference between this year and last year, we're proudly happy to say that we had 15, contestants, and contestants were actually medical students, residents, fellows, junior consultants, and senior consultants. So this is really, thrilling. Now, the other thing that we decided to have a difference between this year and last year is that your vote matters. So instead of having a judgment panel who decides which one goes the first position, second position, and third position, it is actually you who will decide who's going to win. So your vote is going to make a happy evening for someone or few of the contestants, and then the others. So please do not tell anyone that you voted for or against. And so the way that this, contestant or a competition happens, so a few months ago, we published this image competition. And for the image competition, who was eligible to submit an image? Any SSR member and non-SSR member were eligible. So anyone who, was, more than welcome to submit an image. There were definitely images that were to be, aligning and fulfilling the image criteria. So the SSR seeked, images that represent a diverse range of patients that show their characteristic or unusual manifestations of the rheumatic diseases. Images that were not eligible for submission, images that have been published before the image competition submission deadline, or images that are copyrighted. Now, every contestant was supposed to submit a patient authorization and release form along with the submission. Now, as I mentioned, that your vote matters. Now, Jumana and her team, where is Jumana? Okay, so Jumana and her team, they have some technical, advice. So what will happen that I will display an image. There will be actually a total of 10 images that were approved for this competition. So I will show you the image, and along with the image, there will be either a audio-visual, explanation and display of the image. Then you will use this QR code to scan, and so then your vote will be, included. Now you will have only 5 seconds to vote, so please, so there are people actually are running marathon, and we are also running a marathon here. Now the other thing is that do not forget to, press on the send. Otherwise, your vote will not be, included. And at the end, there will be 3 winners. So the first winner will have a check, and his image will be displayed actually at the cover page of the upcoming Annals of Rheumatology and Autoimmunity Journal in the second, quarter of this year. Now, winners for the second and third position will have their images be posted again in the Annals of Rheumatology and Autoimmunity Journal. You know that we're a little bit, not well established financially this year, so we decided maybe next year we will have more and more, sponsorship, so we can actually have also the second and third winners to have some financial reimbursement as well. So, are you ready to start? I don't see any marathon runners here. So, are you ready to start? Yeah, this is it. Jumana, are we ready? Okay. So please lift your iPhones or mobile phones and please scan the QR code. So you will be then in the voting page. So have you all done that? طيب. For the first image, do we see Professor Abdurrahman Al-Arfaj here? No, I don't see him. So what I will do, we were not able actually to record his audio-visual explanation, so I will actually tell you what's there and what's the diagnosis of the image, but then the rest of the images, we have an audio-visual display and explanation by the contestant themselves, so they can actually walk you through the image that they submitted for competition. Okay, Jumana, should we start? Yalla? Okay, so this is a hypertrophic, calcification of the, both shoulders in an elderly, patient. And this image was submitted by Professor Abdurrahman Al-Arfaj. So now I will take you to the voting screen. Okay, so start voting, and remember you have only 5 seconds to do that. Yalla. Do you receive any votes, Jumana? It's not working, so bear with us. Is it? No, now you will be able to, log into it. Just give us a few seconds. Yeah, so now it's working. So don't forget to vote within 5 seconds and please press on send. Is it working? Did anyone was able to vote? Sorry? ما في إرسال? Okay. Maybe we have some technical challenges. IT team, can you please help us sort this out? So, is it working now? Wonderful. So, did you guys receive the votes for the first image? IT? Have you received votes for the first image? Yes? So, should we go to the second image? Wonderful. Okay, so...
My name is Ahlam Zabani, rheumatology fellow on behalf of Dr. Ahmed Abdul Shakur. We evaluated this patient together on our rheumatology clinic. He's a 55-year-old male patient, Pakistani, smoker, work as driver. He presented to our clinic with history of skin rashes over his head and trunk for 30 years ago. It's aggravated by sun exposure. He denied other history of joint swelling, joint pain, oral or genital ulcers. He denied any history of fever, weight loss, loss of appetite, fatigue, no history of chest pain, shortness of breath, no history of medication use, no family history of rheumatological disease, and his systemic review were remarkable. And upon examining the patient, his trunk showed multiple chest hypo and hyperpigmented atrophic plaque with a different size, larger 6 by 7 centimeter, with villus border location is below neck level, indicating the generalized nature on the discoid lobus erythematous, as well as his vertex of the scalp showed well demarcated hypo and hyperpigmented atrophic plaque with overlying erythema and scarring and scarring alopecia measuring approximately 6 by 6 centimeters. We did for him initial blood work, including CBC, liver function test, renal function test, and rheumatological marker were remarkable, except of positive ANA, and serology was negative. His skin biopsy showed interface dermatitis with the basal cell vacuolization, thickened basement membrane, follicular plugging, and perivascular periadnexal lymphocytic infiltrate in the dermis suggestive of discoid lobus. We start him on hydroxychloroquine and we prepare him for anifrolumab.
So if you think that this image by Dr. Ahlam Zabani, Dr. Ahmed Abdul Shakur, is a winning image, so please vote. Can we go for the voting screen, IT team? So don't leave the screen because it's it will automatically be taking you to the voting screen again. Yeah, so it's time for you to vote. And remember, you have 5 seconds, and don't forget to press on send. Same thing, or you're able to. So IT, now they're actually receiving, so just bear, sometimes it's actually your phone's connections, not, not the IT. So are you receiving any votes there? Wonderful. Mishi, did it work with you? It's working? Huh? Because I don't see it here. Ah, wonderful. Okay, طيب. So let's move on. So are we ready to move to the third image? Ready? Okay, IT team, yalla. Turn on the audio visual, please.
This is a 17 years male boy referred from primary health care complaining of progressive asymptomatic soft tissue swelling of the proximal interphalangeal joints and MCPs since 4 years. He reported no joint pain at all. There is no history suggests connective tissue disease or inflammatory arthritis. His father has the same shape of the fingers. On examination, there was only painless saccular subcutaneous swelling around the PI. By reviewing the literature, this patient labeled to be diagnosed as cutaneous fibromatosis, mainly pachydermodactyly. It is a very rare form of acquired benign digital fibromatosis. It's characterized clinically by clinically swelling of the medial and lateral aspects of the proximal interphalangeal joints of practically all the fingers of the hands, with the exception of the thumb. In 1973, it has been referred by various names including knuckle pads, pseudo-knuckle pads, heloderma, and subcutaneous fibroma. Our patient presented a model case with regard to age and sex, as pachydermodactyly is usually seen in young patients, especially at the age of puberty. The mean age presentation is 21 years. Although the age range of published cases is from 5 to 70 years, and the condition is more common in men, with male to female ratio 3:2. This predominance in men has been related to the possible etiology and pathogenesis of the disorders, although this is not yet fully understood. It's been suggested that pachydermodactyly may be reactive disorder secondary to repeated minor exogenous trauma. This proposal is based on finding that pachydermodactyly shows a relationship with numerous occupations and activities such as martial arts and climbing, work in food processing factories, patients with obsessive compulsive disorder associated with tics affecting the hands, also weightlifting. The typical findings are asymptomatic and symmetrical swelling of the sides of the fingers. The second, third, and fourth fingers are most commonly affected, but the fifth finger and even the dorsum of the hand can occasionally be affected. There are usually no epidermal changes, though mild erythema, fine desquamation, or lichenification may be sometimes be observed. hand movement are not affected. The diagnosis is usually clinical. The most typical finding on histology are thickening of the dermis, which may be accompanied by a benign proliferation of the fibroblast and an increase in collagen fibers that extends down to the subcutaneous cellular tissue. Hyperkeratosis may also be observed, as well as decrease in the elastic fibers and mucin. Plain X-ray are normal, and MRI shows an increase in soft tissue volume around. Our patient received triamcinolone injection in the fourth finger as a trial. Unfortunately, our patient lost follow-up in the OBD. We've tried multiple trials contacting the patient. He refused to come to the clinic.
Okay, so this was a case of patchy dermodactyly submitted by Dr. Atif Al-Juhani. So let's please display the voting screen and start voting, please. 5 seconds, press on the send button. Wow, so, okay, so we have approximately 70 voters for this. Okay, wonderful. So let's move to the fourth clinical image by Dr. Intisar Batog, pediatric rheumatologist.
Warahmatullahi wabarakatuh. I'm Dr. Intisar Batog, pediatric rheumatologist from National Guard Hospital in Jeddah. I'm presenting these images for 7-year-old girl who was referred to our clinic with a history of skin rash and pain at the palm and sole, knee and elbow, as well as leg bilaterally, started since age of 1 year. The pain was moderate to severe, occur after prolonged sitting and climbing the stair. This pain preventing her from doing daily activity like school homeworks. The symptoms were not associated with oral ulcer, hair loss, photophobia, nor change in the color of the hand. She was seen in many different local clinics, and the impression was eczema, so she was started on local treatment and without any improvement. Her family history was negative for similar illness, apart from her father complains of chronic abdominal pain, and he was not on any treatment. Clinically, all hair growth parameters below the third centile. The skin rash was symmetrically distributed on her palms, sole, knee, and elbow joint. This is right and left palm showed erythematous, scaly, and hyperkeratotic plaque extended up to the extensor surface of the wrist joint. The second image showed plantar surface bilaterally involved. The red marks showed flaky layers separated from the sole, while the green marks showed hyperkeratotic plaques with some desquamation. The blue marks showed linear crusted, thickened fissure with clotted blood. In this image, we can see all the nails of the toes were affected. The blue arrow showed the nail plate of the first toe on both sides flattened with separation from the nail fold. The yellow arrow showed the nails of the toes thickened and deformed. The pink arrow showed onycholysis of the second toes on the left foot. There was scaly whitish plaque on bilateral knees and elbows. It was non-tender, non-itchy, non-inflamed, silvery, scaly appearance. Our differential diagnosis was juvenile psoriatic arthritis, inflammatory bowel disease, chronic non-bacterial osteomyelitis, and juvenile dermatomyositis. Lab work done for this patient. The CBC was normal and there was no eosinophilia. Liver and renal function was normal. Muscle enzyme and thyroid function normal. Sedimentation rate was elevated 40 and CRP was normal. Albumin normal and fecal calprotectin 261 high. All hair serology was negative apart from anti-LAM in the upper range, and anti-smooth antibody was 140, slightly elevated. Whole body MRI negative for CNO, and the skin biopsy proved to be psoriasis. Management for this patient, she was started on methotrexate, and local treatments was started and initiated by the dermatologist. She was referred to the gastroenterology, and our future plan, if there is any resistance, will start her on Humira or secukinumab. Effective management of pediatric palmar plantar psoriasis requires comprehensive and individualized treatment approach. Given the unique needs and developmental consideration of the children, it's critical to customize the therapeutic strategy to alleviate the symptoms and improve the outcome.
Okay, so a case of palmoplantar psoriasis in a 7-year-old girl with Dr. Intisar Baltog. So please, IT, show us this voting screen. And okay, so but we have approximately 30 voters because it's 5 seconds. So you have to do it within 5 seconds. Lala, it's the same. So it's the same QR code that we started. So it's the same QR code. So you just stay on the same page. It will automatically, take you to the to the next voting screen. Okay, let's move. So we'll display the 5th image.
Assalamu alaikum. My name is Dr. Ghadir Al-Abbadi. I'm glad to be here today to present this case, which is about a 23-year-old female who was presented early on in 2023 with the symptoms including minor rash, alopecia, and positive serology at that time for ANA and anticardiolipin IgG. Later on in August 2023, she presented with a new onset seizure. Her workup, including MRI, were all within normal. So collectively, a diagnosis of lupus with a neurocyclopus was made. With a further careful clinical assessment, she was having other symptoms including puffy fingers, periangular erythema, and subcutaneous hardening in the upper limb, along with difficulty standing from the sitting position. With a further assessment of the lower extremities, it revealed multiple subcutaneous nodules affecting the extensor musculature, anterior and posterior aspect of the thigh. So all of these raises a possibility of overlap syndrome. With a further investigation, including laboratory and image, she was having a normal CK level along with a normal bone panel, including calcium and phosphorus. MRI muscle protocol did not show any evidence of myositis, and her X-ray of the lower extremity, which is showed here, showed a predominantly peripheral and plate-like soft tissue calcification throughout the lower extremities. With all of these, a diagnosis of calcinosis cutis in association with SLE was made. However, all of the suggestive interventions in the literature regarding the treatment of calcinosis cutis did not improve her symptoms much.
So case of calcinosis cutis in SLE by Dr. Ghadir Al-Abbadi. And so remember that you only have 5 seconds to vote. IT, please display the voting screen now. And don't forget to press on send. So your vote will be included in the voting scoring. Okay, stopped, right? So 5 seconds are over. So let's go to the 6th image.
Today we present a complex and compelling case highlighting the favorable outcome of JAK inhibitor therapy in a patient with clinically amyopathic dermatomyositis characterized by anti-MDA5 features and pneumomediastinum. Our patient is a 48-year-old gentleman diagnosed with dermatomyositis. Clinical examination revealed generalized skin ulceration on the hands as shown in image 1, These ulcerations represent one of the hallmark features of dermatomyositis, particularly in an anti-MDA5 subtype. Additional findings included inverse Gottern papules, depicted in image 2. These erythematous papules are characteristic of dermatomyositis, often seen overlaying joints and extensor surfaces. Further dermatological manifestations include ulcers on the elbow, showcased in image 3, and thighs, showcased in image 4, a skin biopsy taken from the right wrist revealed interface dermatitis, consistent with the diagnosis of dermatomyositis. The patient presented with dysphagia and progressive interstitial lung disease, or ILD, but notably denied any signs of proximal or distal myopathy. This constellation of findings pointed to the anti-MDA5 amyopathic dermatomyositis subtype, characterized by severe skin involvement and rapidly progressive ILD. Initial treatment consisted of pulse methylprednisolone, intravenous immunoglobulin or IVIG, and cyclophosphamide. Mycophenolate mofetil or MMF was subsequently introduced. Despite these interventions, the patient failed to achieve clinical stability with worsening ILD over 3 months. The patient's condition deteriorated, culminating in an emergency department presentation with pneumomediastinum, visualized on chest CT, with extensive subcutaneous emphysema, showcased in image 5. Image 6 illustrates the subcutaneous emphysema on a chest X-ray, highlighting the severity of this complication. At this stage, treatment was intensified with high-dose prednisolone, IVIG, rituximab, and cyclophosphamide, while MMF was discontinued. However, the patient's clinical condition continued to decline, necessitating high-flow nasal cannula oxygen therapy. In light of the patient's deteriorating status, a trial of tofacitinib, a Janus kinase inhibitor, was initiated. Cyclophosphamide was discontinued, and within weeks, significant clinical improvement was observed. Radiographic imaging demonstrated resolution of the pneumomediastinum and subcutaneous emphysema, as shown in image 7. Clinically, the patient's oxygen requirement decreased, allowing a transition from high-flow nasal cannula to low-flow oxygen at 1 to 2 liters per minute. This case underscores the potential of JAK inhibitors like tofacitinib in altering the trajectory of severe and refractory complications in anti-MDA5 dermatomyositis. The patient's improvement not only highlights the drug's efficacy in controlling inflammation and halting disease progression, but also provides hope for patients facing similar challenges. He was subsequently discharged and remains under evaluation for future lung transplantation.
So Dr. Huda Al-Ashkar presented a favorable outcome of JAK inhibitor in anti-MDA5 induced anti-MDA5 dermatomyositis associated with pneumomediastinum. So your voting started already, and please vote and don't forget to press on send. Poll is closed. Okay, wonderful. So, you have to be quick. أعطيكم فرصة. Okay, hey, you have to be ready. Okay, let's move on to the 7th clinical image. Dear IT team.
Assalamu alaikum wa rahmatullahi wa barakatuh. Dear professors and colleagues, presenting to you a case of unilateral vasculitic skin ulcers in a 22-year-old Egyptian lady after she experienced a cut wound
in her left dorsum foot. The patient presented with those ulcer in left lower limb after 7 days following a cut wound in the dorsum of her foot by a knife. Upon examination, oral and genital ulcers were observed. Laboratory investigations showed positive HLA-B51 testing, and Behçet disease diagnosis was confirmed by an experienced oral medicine physician.
Okay, so a case of unilateral vasculitis with skin ulcers in a patient with Behçet's submitted by Dr. Nisreen Abu El-Adil from Egypt. Let's display the voting. 3, 2, 1, and voting is up. Okay, so let's move to the 8th clinical image.
This is a case of a 49-year-old female was referred to rheumatology clinic in 2019 as a case of arthritis, dry eye, dry mouth, and profound hypokalemia. She was found to have positive rheumatoid factor, strongly positive SSA, SSB, and minor salivary gland was showing periductal and perivascular lymphocytic infiltration. For that, we labeled her as a Sjogren syndrome, and we asked for a nephrology opinion. The nephrologist was asked for kidney biopsy as a profound hypokalemia and proteinuria. The biopsy was suboptimal with a final result of tubulointerstitial nephritis. Since that time, she was maintained on hydroxychloroquine, prednisolone, and long-term potassium supplement. On the late of 2023, she was presented with increment in her creatinine level. Urine analysis was normal with no proteinuria, no sediment. For that, ultrasound QB and nephrology opinion has been requested. The ultrasound was showing bilateral medullary nephrocalcinosis for CT2 confirmation, and we did CT and it was supported the diagnosis of bilateral medullary nephrocalcinosis. So finally we labeled her as a Sjogren syndrome with a distal renal tubular acidosis complicated by nephrocalcinosis.
Okay, nephrocalcinosis in Sjogren's by Dr. Vawan Aswat from Al-Taif. Please vote. Okay, so now we have 2 more images, IT team. So image number 9.
Assalamu alaikum. I want to share with you this interesting image. This is a hands x-ray of a man in his 50s who came to my clinic, referred from dermatology clinic with the diagnosis of skin psoriasis, psoriatic arthritis. He was on anti-interleukin 17. He was referred for evaluation and optimizing the treatment as he's having pain, stiffness in his fingers with advanced deformities. The X-ray revealed that he has typical X-ray findings of both psoriatic arthritis and rheumatoid arthritis. There are a lot of findings in this X-ray. If we say from the psoriatic arthritis side, you can see the proliferative erosions in the PIP joints. And you can see also here pencil and cup in D4 and D5 of his left hand. From the rheumatoid arthritis side, you can see the periarticular osteopenia, joint space narrowing almost in all his MCP joints, also in his both wrist joints and the carpal bones also. You can see also that there are multiple periarticular erosions in all MCP joints. With subluxation destruction in the MCP1 of the right hand. Also, you can appreciate that both styloid processes are totally eroded. I decided to share with you this image as through my practice, this is the first time I come across such a case. I stopped his anti-interleukin 17 and put him on combination of methotrexate and anti-TNF alpha. In his follow-ups, he was very satisfied and he was doing much better. Thank you.
So, advanced radiographic features of psoriatic arthritis by Dr. Sami Abu Ajmiya. Please vote. Okay, sure. So let's move to the last image.
Assalamu alaikum. I will present an image of large pool measuring around 10 cm on the anterior aspect of the knee. This picture of a patient started to have multiple thrombosis in December 2021 and initially treated with IVC filter and rivaroxaban. Thrombophilia workup was done at that time and showed positive antiphospholipid antibodies. And shortly after, the patient started to have bullous lesion and referred to our center in mid of 2022. At that time, she had malar rash as well. And SLE workup was done and showed positive ANA, elevated double-stranded DNA, along with positive anti-cardiolipin IgG, and RNB and anti-SSA. And then the patient started on plaquenil and mycophenolate acid analog. And within 4 months of treatment, the patient improved dramatically with post-inflammatory hyperpigmentation. So this picture is about bullous systemic lupus erythematosus, which is a rare blistering manifestation of patient known to have SLE, and could be the first sign of SLE. There is limited data in the management of bullous SLE. The first line is Dapsone, however, it was not available in our center, so the patient was not started on it. The other option, including steroid-sparing agents such as cyclophosphamide, azatioprine, mycophenolate acid analogs, and rituximab. In this case, the patient was treated with the Myfortic and improved dramatically without any surgical intervention.
Okay, so bullous as a rare manifestation in patients with lupus, submitted by Dr. Zainab Al-Rabia. Please start voting once you see the voting screen. Yes. Okay, I think Jumana. So no more images, right? So we have 10. Yeah. So now, by the time the IT team calculate the scoring, please use your keyboards in your phones to describe in one word your overall experience about the 11th Saudi Society for Rheumatology conference. And we would like to see your responses here. Meanwhile, I would like to invite Dr. Hanan Al-Reis, the president of the Saudi Society for Rheumatology, Dr. Fahid Al-Anizi, the head of the scientific committee. Please join me on the stage so we can announce the first 3 winners. So if you keep your eyes on Jumana, she's actually bringing the voting results. Okay, so let's see, what do we have? Perfecto, good, wonderful, amazing, excellent, enjoyable, outstanding, awesome, great, world class. She needs, a clap of hands. And exciting, excellent, nice, informative, optimal, beautiful, stunning. Alhamdulillah. Okay. Dr. Fahid was reminding me that last year I did this. Just to announce, so I will do it this way. So I will announce first the third place winner. And then we will see who got like the first place and then the second place. So the third place winner award goes to the image that was submitted by Dr. Rawan As-Suwat from Al-Taif. Do we have Dr. Rawan? Dr. Rawan? Rawan? Okay, so please join us on the stage. So Dr. Rawan As-Suwat, your image will be displayed and be included and will be published in the upcoming edition of the Annals of Rheumatology and Autoimmunity in the second quarter of this year. Now, those who are actually competing for the first and the second prize or award, so I will say them but without any order. So we have an image that was submitted by Dr. Huda Al-Ashgar and Dr. Hussein Halabi from Jeddah. And we also have an image that was submitted by Dr. Zabani and Dr. Ahmed Abdul Shakur from Al-Medina. Okay, so adrenaline is heating up, right? So the first prize award goes to Dr. Huda Al-Ashqar and Dr. Hussein Halabi from Jeddah. Congratulations. Please, Dr. Ahmed, Dr. Zabani, Dr. Huda, Dr. Hussein, join us on the stage. Congratulations. And I will just echo what was mentioned yesterday by Dr. Halabi in the Jeopardy, that everyone is a winner. We had this image competition for fun, to learn actually from some. I personally learned a lot from these images. And of course, we're actually in the process of creating the SSR image bank. So all these images will be included after permission into the banks. So Dr. Hanan, the mic is yours. Okay. مبروك. Thank you so much. And ثلاثة. Okay. Okay. Dr. Ahmed, please join us.
نبغى البول حق المشاركين. راح نعمل السحب الآن على الحاضرين اللي حضروا لنا آخر يوم في المؤتمر. We'll take three names.
So I think دكتورة ميساء الطيف. دكتورة ميساء، بس إن شاء الله أنا قلت الاسم صحيح. دكتورة ميساء she's here. خلاص we'll cancel this name. Please with mine. احنا في صعوبة في كتابة الأسماء عندنا موجودة. طيب so I think his name مناع المطيري. مناع المطيري. Next. أسد الله. Okay, we are here. Thank you so much for your attendance. All the activities of our conference. Thank you so much. Please. عليكم السلام.
Dr. Asadullah, he came from Dubai and he attended the whole conference regularly. That's why he is there. يلا بسم.
ليلى محروس. ليلى محروس. ليلى محروس. مبروك.
دكتور محمد القصب موجود؟ القصاب محمد القصاب هذا أشوفه دائما يحضر. دكتورة أسماء حجازي.
ختامها مسك. Thank you very much. With this we conclude our symposium, the 11th symposium للجمعية السعودية للأمراض الروماتيزمية. أتقدم بالشكر للدكتورة حنان الرئيس، دكتور فهيد العنزي، جميع من شارك في اللجان المنظمة للمؤتمر. أشكركم جميعا على حضوركم، وإن شاء الله نراكم السنة القادمة في جدة بإذن الله. مع السلامة.
السلام عليكم ورحمة الله وبركاته. حقيقة نحن استمتعنا جدا خلال ال4 أيام. المؤتمر كان رحلة علمية اجتماعية تعارف. خرجنا بأفكار كثيرة، خرجنا بأفكار بحثية، خرجنا كسبنا شوفتكم ومعرفتكم ومعرفة الكثير من الأطباء الخريجين الجدد. Just because we have Prof. Sondo with us from the day one, just quick English word. So as we conclude the 11th Saudi Society of Rheumatology, we have shared a remarkable journey over a few days. We gathered not only for exchange knowledge and idea, but to strengthen our community of rheumatology. And we have been updated with a lot of knowledge from an expert speakers. We have met our colleagues from all over the kingdom, from the Gulf region, as well as from the international area. And everybody, alhamdulillah, was happy. And we wish to be more and more collaborative in all aspects. And we'll see you, inshallah, next year in Jeddah. Next year it will be the 12th Saudi Society of Rheumatology in collaboration with the Gulf Society. So thank you for all of you. Thank you for the speakers, for the chairperson. Thank you for all the organizing committee, the scientific committee, all of you. Thank you for the elite company for an excellent organization. Thank you for all drug company for their support. Thank you for all of you sitting continued till the last minute of the conference. So kindly come to take a group photo all together. So this is the best photo because you are the one who stayed with us till the end. Thank you all.
Please, I'd like to all of you just to join us to take a photo. Please don't feel shy. Just come here the stage. Anyone who would like to come, please, he or she's welcome. The organizer company, please join us, please. You are part of our success. Please, just come. Don't feel shy, just come. Ahmed Khattab, please come, and your colleague, please come. Jumana, Umriya, Salma, please come, just join us, please.
Kindly come for the last photo. فين أميمة؟ شو اسمه؟ أمنية. أحمد، فين أحمد؟ Where is Jumana? All of you. طبعا they did amazing work. Jumana, أمنية. وين دكتور أحمد خطاب؟ فين دكتور أحمد؟ ما في؟ موجود؟ شكرا لكم كلكم، الله يديكم العافية.
الله يسعدكم، أنتم سبب النجاح، وجودكم ومشاركتكم وتعبكم هو سبب النجاح. شكرا ميسون كثير. شكرا دكتور فهد على التعب. شكرا أريج الحارثي، هي الوحيدة بقيت من الأورجنايزيشن، كنا بنديك سبيشال سيرتيفيكيت. تعال فين اللي يصور؟ تعال في الصورة، أبغى تدي أريج هدية.
Ultra